Yeah. Well, welcome everyone to the August meeting of the Oregon Health Policy Board. My name is Chris Smith, and I'll be chairing today's meeting. And just thrilled to be here in an in-person meeting with all of you in Medford. So we will have both our in-person participation and we have online participation via Zoom today. We are at the On Track Road Valley Outpatient Services. And it's thrilled to be here. So thank you, Summer Wolfert and the team for inviting us to use this beautiful training room. This is amazing. For today's meeting. For those joining us on Zoom, the Zoom chat feature in today's meeting only allows meeting attendees to message the host and co-host and no other meeting participants. So any questions, thoughts, comments can be sent via Zoom chat to the meeting host, co-host, with everyone. And if you have a supporting resource link to share with meeting participants regarding an agenda item currently being discussed, share that link with the meeting host or co-host to share with the meeting attendees. All materials for today's meeting are available on the Oregon Health Policy Board website, hyperlinked in today's meeting agenda.
Can we do a quick audio check to see if people online can hear us?
I think Tony, can you hear us? Give us a thumbs up. Oh, thank you, Tiffany.
I have Tony, maybe it could be your system. All right, let me. Okay. Okay, let's proceed. I think Tony needs to restart.
Okay. Well, I will proceed with each month we start our meetings by reading our health equity definition. We rotate who has the honor of doing it, and this month it's mine, so you get to hear more of my voice. All right, but there you go. Oregon will have established a health system that creates health equity when all people can reach their full health potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, age, gender, gender identity, sexual orientation, social class, intersections among these communities or identities, or other socially determined circumstances. Achieving health equity requires the ongoing collaboration of all regions and sectors in the state, including tribal governments, to address the equitable distribution or redistribution of resources and power, and recognizing, reconciling, rectifying historical and contemporary injustices. Hold that with us as we proceed through our meeting today. Topics that we will cover in today's meeting, we'll kick it off with an update from the Oregon Health Authority, welcoming director back. And then we will have an overview from the On Track Road Valley Agency, our host today. Have a community panel with partners from the Birch Grove Collaborative, which we're especially excited for. Public comments. We'll revisit the guiding principles for Oregon's healthcare market oversight, the SITMO program. And then the Health Equity Committee has a request for membership approval. And we'll have some closing comments and adjourn our meeting. So I do want to oh yes, we do need to do roll call.
Okay. Great. No worries. I'll start with our membership roll call. Peter Starkey.
Here.
Bill Kramer.
Here.
Brenda Johnson.
Here.
Kirsten Isaacson.
Here.
And we saw Tony German online. I don't know, Tony, are you back? Can you hear us? No, I know he was rejoining. Okay, give him a minute. Melina Moran will join remotely in about 30 minutes, and Dr. Jimenez will be absent today.
So especially if Tony is, I think we need to wait to vote on the minutes until Tony returns.
Have 4 members, which I believe is 4 for us.
Okay.
So we have 7.
I was
But we can wait for Tony. Yeah, we can wait for Tony.
I'm going to have to abstain. So.
Oh,
Oh. Yeah, it's 8:36, I think, Director Hoppy was expecting us at 8:35, so maybe we can meet to Director Hoppy. But before we do that, I do want a quick note on conflicts of interest. This is the recent addition for us, just before we begin each meeting, after we review the agenda, remind board members of our obligation to disclose any actual or potential conflicts of interest and like. No conflicts. So upon reviewing today's agenda, if you have a financial interest, professional affiliation, or other relationship that could be reasonably perceived as influencing your decision or participation in today's discussions, let's say we're creating a moment to share those for the record. You should share any actual or potential conflicts of interest. This transparency helps ensure the integrity of our work and maintain public trust. But would any members like to share an actual or potential conflict of interest at this time? Great. Although it always is great to share them too. Then we will move on to. We welcome Director Hoppy. Director Hoppy.
I don't see her name. She may be on the phone.
Okay.
Dr. Hoppy, are you there on Zoom?
Okay. Well, maybe we will take a moment to approve our August meetings if 4 equals quorum. Which we know we have that. So or the July meeting, pardon me. So the July 1st health policy board meeting minutes. They're number 1 in today's meeting packet. And is there a motion to approve the draft OHPB meeting minutes from July 1st meeting?
So moved.
Second.
Okay.
Thank you, Bill. Thank you, Brenda. All those in favor of approving the July meeting minutes?
Aye.
So just for I'm forgetting that we are switching to roll call voting, but for the record, I heard an aye from Peter, Brenda, and Bill.
And Tony German, can you hear us?
Tony's back.
Sorry about that, present.
Okay, and we're taking a vote on the draft July meeting minutes.
Approve, Tony German.
Okay, great.
Person, I vote to abstain of FMP.
Okay, great. And Dr. Hoppy is now joined us too.
Excellent. Well, welcome, Dr. Hoppy, OHA's director, joins us remotely this morning to provide agency updates. Good morning, Sejal. Thank you for joining us for these important and timely updates, and begin whenever you are ready.
Awesome. Thank you for the opportunity to be with you all today virtually. Today, I'm providing an overview of some of our more recent federal response planning teams' efforts and highlighting emerging pressure points and some work ahead as we navigate this moment. As you know, we continue to operate in a rapidly evolving landscape, one shaped by significant funding uncertainty, intensifying policy demands, much of them induced by abrupt federal policy changes. These pressures require us to stay nimble and coordinated and unequivocal in our actions and our values, and that's what we have sought to do. Across every division, our teams have remained focused and resilient. They continue to operate with flexibility, discipline, and a deep commitment to the people of Oregon. And we continue to coordinate closely, too, with our sister agencies and with the governor's office to ensure alignment across the enterprise. Amid all of this, significant changes lie ahead. The passage of H.R. 1 poses major threats, as you know, to Oregon's food and health programs. federal funding cuts will create gaps that the state budget cannot fill. And as a result, hundreds of thousands of Oregonians may lose access to care. While we are working closely with the governor's office and analyzing internally to assess the full impact, early projections suggest that the state could lose over about $10 billion in Medicaid funding once all changes are implemented. In addition, HHS's 2025 Marketplace Program Integrity and Affordability Rule introduces sweeping changes that begin in plan year 2026. As an example of some of these, DACA recipients will lose eligibility for both Marketplace and OHP bridge coverage at the end of this month. Gender affirming care will no longer be covered as an essential health benefit in ACA compliant plans. The special enrollment period for individuals below 150% of the federal poverty level will be eliminated. The annual enrollment period will be shortened to 60 days by 2027, and auto re-enrollment in the Marketplace will be discontinued. All of these changes are an attempt to destabilize the health system and make it less likely that individuals can retain coverage and care. In keeping with our commitment to transparency, we have worked closely with community partners and with ODHS to inform Oregonians of these changes and their potential impacts through webinars, partner messages, and informational materials, and we will continue to do so as these changes take effect. Our goal is to minimize the harm from these policy shifts and to safeguard coverage and care for as many Oregonians as is possible. That is a work in progress. I also want to provide an update on our implementation of the OHPB and Health Equity Committee's recommendations on gender affirming care. This spring, OHA convened an internal work group to review and act on the recommendations of the Gender Affirming Care Provider Work Group and the Healthcare Workforces Committee's Needs Assessment. In June, OHA leadership received a plan to move these recommendations forward, and last week, we committed to providing the requested support. Meanwhile, we continue to monitor and evaluate relevant federal developments that may impact this care. Let me be unequivocal. Gender affirming care remains protected under Oregon law. And we acknowledge the stress and the fear that national discourse and policy shifts are causing for patients, for providers, and for communities. In response, we are hosting listening sessions. We are talking with those that are most affected, including trans and gender diverse individuals, providers, advocates, and CBOs across the state. We remain committed to protecting essential benefits, which means upholding state law and supporting the trans and gender diverse community and providers of gender affirming care. Let me also briefly address reproductive health funding. As many of you know, H.R. 1 prohibits certain entities from receiving federal Medicaid funding for 1 year. OHA has determined that both Planned Parenthood Columbia Willamette and Planned Parenthood Southwestern Oregon fall under this prohibition. To mitigate this anticipated impact, the Oregon legislature did allocate $10 million in one-time state funding during the last session. These grants, administered through the Reproductive Health Program, are intended to preserve access to comprehensive services statewide. Those contracts are currently under legal review, and OHA is working closely with both affiliates to distribute funds quickly. We are also closely monitoring federal litigation in Massachusetts related to H.R. 1 and will continue to coordinate with our partners as that litigation progresses. But for now, both affiliates may submit claims as usual for services to OHP and to Reproductive Health Access Fund patients. Both clinics can continue and are continuing to accept Medicaid patients, and no changes in service availability are in effect. Now more than ever, OHA remains steadfast in supporting the life-saving work of these and all our reproductive health partners. I also want to touch on the legislature's recent investments in hospital maternity services. We are pursuing CMS approval for enhanced direct payments to rural type AB hospitals that offer maternity care. If approved, this would represent a $37.5 million increase in 2026 to these hospitals. We are also pursuing a parallel increase in diagnosis-related group payments, which we incorporated into 2026 Medicaid CCO cap rates. These investments collectively aim to stabilize and to expand access to maternity services across Oregon. In a time marked by uncertainty and potential scarcity, our work demands more than routine operations. It requires constant alignment, strategic clarity, and unwavering commitment to the people we serve. I am proud of how our federal response planning team and frontline staff have stepped up in this moment and of the partnerships that make this work possible across state systems, in local communities, and with this board. And I look forward to continuing to provide updates over the months ahead.
Thank you, Director Hoppy. Appreciate the update and the work. Do board members have any follow-up questions?
I can't quite catch that. Can you come again?
I was just thanking you for the update and seeing if board members have any follow-up questions. And it looks like Bill, go ahead.
Bill Kramer, thank you, Dr. Hoffey, for that summary. I really appreciate the clear-eyed view of the problems caused by the loss of funds under HR 1 and the regulatory and legal changes as well that are adversely affecting everywhere in Oregon. You went through some of the impacts of the marketplace rule. Could you describe a little bit more about what's being done by the state to communicate this to current enrollees, what their options are, what the process is going to be, and what options there might be for helping those people who are currently enrolled or risk of loss to become enrolled in other kinds of programs or otherwise get health care?
Thanks for the question. And I would say you have a resident expert in the marketplace sitting beside you in Claire, and I'm sure she'd be happy to elaborate on this throughout the course of the day. But for now, I will say that our goal here is to minimize coverage loss and maximize communication, proactive communication with enrollees to ensure that they have what they need, all the resources and information that they need to stay enrolled if and where possible and whatever coverage plan may be available. That will not always work out for all, but we are, as I mentioned earlier, working with our community partners, our navigators, ODHS, to provide as many informational materials, webinars, and partner messages as is possible to communicate about the impact of these changes. And we're continuing to do so, continuing to evaluate how better we may engage with and reach folks on the ground who are most likely to be directly impacted by these shifts.
Great, thanks, Kramer.
Brenda.
Thank you. This is Brenda Johnson. Dr. Healthy, I appreciate the reflections. I'm wondering if you can elaborate a little bit around the Healthier Oregon program and vulnerabilities for immigrant and refugee members across the state who are concerned about maintaining provision to healthcare resources and benefits in the group.
So I didn't quite catch the latter part of your question, Brenda, but I think you're referring to care for our immigrant and refugee families. And we know that this is a particularly fraught moment for them, given recent news. We've begun to work with our community partners, those that serve these populations, to share what we do know and what we are continuing to evaluate, especially in response to recent federal data requests. We recognize there's a lot of fear and there's a lot of uncertainty. And I would recommend that patients continue to talk with their healthcare providers to learn more about the data sharing and privacy practices at those individual facilities as we evaluate how best to respond to recent federal requests, as well as the uncertainty of this moment. And I recognize that's unlikely to be satisfying to many, and at the same time, that's where we are.
Tony?
Thanks a lot, Dr. Harvey. Appreciate your transparency and clarity, and the resources. I had a curiosity, and I know this is wheels in motion. One of the difficulties that we're going to face is actually something we've done really well with redeterminations, and that's with the work requirements. That's probably where the majority of loss of coverage will come from. And we excelled at this post-COVID. And just curious about, I'm sure this will be a discussion ongoing in OHA, but bolstering up the tools and what the learning that we've had, also leveraging technological advances as far as facilitating determinations whether somebody qualifies for Medicaid. Just curious about the department's thoughts or resources that we collaboratively can be from OHPB to kind of support that, if that's legislatively. Just, we don't have an answer today, but thinking about supporting that in a short session regarding, what tools or staffing as far as benefits coordinators, somebody to determine. We're thinking about that within my own organization. Do we need to hire more individuals to do outreach? We know that that's the challenge, is getting people an awareness that they have to redetermine every 6 months. So just thinking about that in that space, and whether somebody qualifies for TANF or other programs that would qualify in this space. How can we, leverage technology to streamline that?
Tony, I think you're asking all the right questions, so I really appreciate that ideation and also that offer for help. We are only beginning now to mobilize internally and in partnership with ODHS to identify how best to operationalize the massive systems, ITs, community engagement that will be required to not only just comply with the letter of the law, but also we're doing so in a way, again, that minimizes harm and protects those populations most at risk. And these are the exact questions that we are asking. What can we learn from prior efforts, PHE unwinding, work requirements, implementation in other states? How can we better leverage existing technology systems? Where will we need to make new investments? How can we partner with community-based organizations on the ground with providers? What sorts of guidance and supports can we offer there? Recognizing, of course, that all of this requires investment, but to ensure that we are as seamlessly as possible reaching people in need and trying to simplify the enrollment process, the interpretation of these new requirements. It's going to take a lot of work and a lot of partnership, and there are going to be bumps on the road as we figure this out collectively. And so in that spirit, I just really appreciate this board's ideas and input about how we can roll this out most effectively and supportively for our members.
That's great. Thank you. And if I could ask one other question or just a comment observation, I know we talked about this the other day as far as the Personal Responsibility and Work Opportunity Reconciliation Act that is impacting community centers, health centers, and clinics. And it seems like it's under open review at this point. I was wondering if what space or OHA or the governor's office, and maybe you can't necessarily speak to that, but providing comment with regard to the pullback of that prior policy. Obviously, in a number of clinics that are serving undocumented individuals, quite worrisome regarding the impact that might have. And just curious, any comments about any pressure or support on the rescinding of that prior policy?
I would say in terms of pressure or support, we share your concerns, and we're talking with our congressional delegation. We're talking with our partners and counterparts in other states about how they are responding to that directive. And at the same time, a lot of this is in flux as legal challenges will inevitably unfold. So we are sharing as much information as we can about how to respond to those shifts, and at the same time, we're continuing to figure things out and evaluate the path forward.
Appreciate it. Appreciate all you guys are doing. Thank you.
Thank you, Director Hoppy. And I also want just double down on that offer. I think not only will we continue to think through ideas and suggestions, but I think as much as OHA would benefit from support of OHPB as we move through short session, special session, whatever, in terms of having the resources to guide what will come or to do all the work that is involved in these redeterminations. Please consider us. We're happy to do that as well. Thank you, Dr. Hoppy, for joining us this morning. Welcome back. We're thrilled to see you.
Thanks very much for having me.
Hey. Next up, I am very excited to introduce, welcome Summer Wolcott, who I have not met yet. I don't know who I'm turning this over to. Great. Executive Director of On Track Rogue Valley, our host today. Appreciate that. Shared an overview of On Track Rogue Valley. So thank you so much for joining us and letting us sharing this amazing space with us. And we look forward to learning more about On Track.
Great.
And when you're ready.
All right. Well, thanks everybody for being here. And for those of you who had a journey to get here, we appreciate you coming down and checking out the services that we have. I think Jackson County specifically is really unique in our collaborations and innovation, figuring out ways to work together. And so, yeah, welcome. This space is frequently available as long as it's not on a Wednesday. So you're always welcome to reach out if you need it. I'll be really, really quick because it would be annoying if I wasn't. On Track, we are in Josephine and Jackson counties. We have a full continuum of services for people with substance use disorders. We've really been ramping up our mental health treatment so that we can provide co-occurring services. All of our outpatient programs now have co-occurring support available. And our bilingual, bicultural, Latino services have also been a huge priority. So we have we have bilingual, bicultural staff for all of our outpatient SUD services and our housing services. Not yet for residential, but that's coming soon. All of our programs are CARP accredited and really focused on embedding peer support across each of the kind of connections between our different levels of care. So they're embedded throughout our programs. Kind of going through our programs and services really quickly. We have our outreach and mobile assessment teams. Those are our traveling folks that go around to different places. Somebody's in jail or they're in the emergency department. A lot of times it's pregnant women who are getting ready to give birth and have a substance use disorder and need to get access to a residential treatment program. We can send certified alcohol and drug counselors on site to do assessments and intake paperwork there to make it really streamlined for folks when they are, leaving whatever setting they're in. They can go directly into their service without having to have an added step of getting in, going through an intake process first. We have youth and adult services. We've really started ramping up our youth services with our school-based prevention and SUD treatment staff. They're trained in teen intervene, which is one of the few evidence-based teen prevention curriculums that isn't just about nicotine or alcohol or marijuana. It's, a more broad range. So that was in partnership with public health and the city and the schools, and that's been going really well. We have our, on this site, we have child watch services here. It's like right there in this building, so that if folks come and they have little kids, they don't have to choose between coming into treatment and outpatient and having a safe place for their little people to hang out. So that's funded by SAMHSA, which is concerning. Right now, it's funded by SAMHSA, but that's in place. And we have, the other thing that we have going on at this site is our Recovery 360 program, which is in partnership with Jackson County Mental Health, Compass House, and Paradigm. That's for individuals who have a severe persistent mental illness, substance use disorder, and forensic involvement. So they're a lot of times they're the individuals who are kind of in and out of the state hospital and jail. And they're upstairs hanging out with our crew for about 30 hours a week at this point. And it's going really well. There's the maximum is 10 people up there. Any more than that, and it starts to derail pretty quickly. But that service we added, it's probably 2 years now. I think it's been going for 2 years. And has, we're starting to finally get some outcomes from that. So that's been an exciting addition. Our residential treatment, we have, the first kind of step in the residential treatment process isn't just for our residential. We added emergency lodging for folks that are pre-treatment. If they're unhoused, they have severe substance use disorder, and they're on one of the many very lengthy wait lists for a residential treatment or detox bed across the state. It doesn't just have to be ours. They can come into our emergency lodging programs, which are all single occupancy bedrooms with common areas with like laundry and showers and all of those things in case managers on site. They don't have to stop using to be there. So it's our only really truly low barrier housing that we offer. All of our other housing services are after, their recovery housing. And interestingly, the timing of this, we're about to have 40 of these different units across Jackson and Josephine County. And Oregon might have an opportunity to tap into federal dollars with the newest executive order on ending vagrancy and the crime of being unhoused in the United States or whatever the nonsense is, because this model actually weirdly aligns with getting people into treatment. And it's very successful. Right now we're at 68% success rate of people who are coming in from being unhoused. Most are chronically unhoused, and 68% of them are successfully getting into a treatment bed across the state. Yeah, 68. It's crazy. And what we're seeing in that process is not just the success of getting those folks in, it's that they're naturally reducing use. Because they're in a safe place, they have their basic needs met, they can decompress and just sleep for a couple of days and not worry about their belongings. And we're able to improve utilization of the residential beds that are across the state, because we can get them to their bed when it's available instead of having people no-show for intakes because, they forgot or they couldn't get a ride or the various things that happen. So it's an interesting model that might be an option for tapping into some federal dollars with the nonsense that's coming out of the federal government. You don't mind me calling it nonsense? Then we have our moms and dads programs. Those are residential treatment for parents with their children, ages 5 and under. And we have a licensed child care on site of moms. Our Mountain View Recovery Center is adults of all genders, so it is one of the few places where it's really just kind of a non-issue. Whether what gender somebody is, because it's single occupancy rooms and it's not just for men or just for women, it's just for people. And then, of course, we have our transitional housing. We have 5 locations for transitional housing right now. All of those are family friendly so that people who are coming out of the moms and dads can step down with their kids, get on their feet for about 6 months. And then we have 150 plus units that are more permanent second chance housing. Our next up kind of grand finale that we're working on is the family treatment campus, which is coming soon for people who are local. It's the Cobblestone Village campus, and construction is underway. Our goal there is to really interrupt the intergenerational cycle by not just providing treatment for the parent or the child, but to have both specialties on one campus. With the residential side, you'll have 42 beds, 16 for dads, 28 for moms, licensed childcare. And then the other side of the campus is the full continuum of adult and child outpatient continuum, including medical, psychiatry, and math. That should be open fall of 26. So that's on track. That's what we've got going on.
Incredible. Thank you so much for sharing this incredible work. Any questions? Well, I'm trying to get a lot of fans before we got here. Many kind words were said. So appreciate your hosting, sharing more about organization. Great to hear that there's, maybe a opportunity.
Let me know. I can package it all up for you. It's cheap too. Emergency lodging.
Thank you. I do want to recognize that Melina has joined us. Welcome, Melina. We're happy to have you. Hi.
Good morning, everybody.
Great. All right. Hey, well, with that, we'll move to our panel of the day. Community panel consisting of partners from the Birch Grove Collaborative. Very excited to welcome and hear from all of you. I'd like to turn it over to Stephanie Lyons, Director of Birch Grove Collaborative, to kick off the presentation and community panel.
Thank you. Thank you. My name is Stephanie Lyon. I serve as the Behavioral Health Collaborative Director for La Clinica and as the Birch Grove Collaborative Director. And today we have a presentation and many panelists that are leaders of the Birch Grove Collaborative. We do this work together in Jackson County. And I'll first just talk about the model, and then each of our panel members, many of our panel members will be presenting on some of the slides. I'd like to ask that we can hold questions till the end. There may be questions that come up, as many do. And that way we can get through basically the concept of the model and the history and all the information there. And then we will have time for questions at the end. So the Birch Grove Collaborative consists of 9 organizations working together in Jackson County. And we all serve and have a delivery system, a model of care to specifically serve people in our community with underlying mental health and or substance use conditions. And we provide their medical, dental, pharmacy, housing, and substance use disorder and mental health treatment in a very collaborative way. And so you can hit next on the slide there. Yes. And that's that's what we do, and it's pretty complex, and has taken many years to build. And you'll see all of the different organizations there, and many of them will be presenting today. From our two All Care Health and Jackson Care Connect as our Oregon Health Plan providers, Addictions Recovery Center, and On Track as our substance use disorder providers. And then we have Columbia Care and Options and Jackson County Mental Health, providing our specialty mental health. All of them also have a blend of mental health and substance use within their organizations and provide care there. And then also Jackson County Community Justice works with us closely. And then our most recent addition to our collaborative is Opportunities for Housing Resources and Assistance, our ORA partner. They provide temporary shelter in Jackson County. And La Clinica has a small clinic embedded inside that shelter. So that's a new model that we're experimenting with. So we just started with that pilot a couple of years ago. We could forward to the next slide. Yes. So the model of care. These services are provided, you can go ahead and click on the next one. They're provided through on-site, virtual, and field-based services with these integrated partners working very closely together on shared patient caseloads and patient panels. We have a shared workforce. We do joint staffings and shared care plans together. Doing treatment plans to meet all the needs of an individual in our county that may be needing that higher level care coordination. Often they're unable to access these services directly on their own. And we really have a great model of no wrong door. So people could enter at any one of these points and then access our services. We also receive referrals from many other partners in our community. These are just our collaborative that work together closely in this formal model. We have clear workflows and referral pathways to one another in providing that care, and just some really cool collaboration among the partners. And of our partners at the La Clinica Birch Grove Health Center, we actually have embedded Options, Columbia Care, for specialty mental health, and then Addictions Recovery Center and On Track. They have staff that are actually on site at the clinic. And now I'm going to turn over the next part of the presentation with the history to Stacy Brubaker, and if you'll introduce yourself and where you're from, and then.
Good morning, everyone. I'm Stacy Brubaker. I'm the Department Director for Jackson County Health and Human Services. At the time of the creation of this collaboration, I was the Division Manager for Jackson County Mental Health. And as I look around this room and start this conversation, there's only two people in this room that were part of that original conversation, which is myself and Brenda. And what I remember about the first conversation was we were at a CCO conference up in Portland, and I, for some reason, got the biggest room. I don't know why, but we all met in my hotel room because there was a table there, full on table. I don't know why I got the luck of getting a big suite, but we all met in that room, and really the first question was, what can we do and how can we make it better and different? And really try to figure out the best way to serve these really complex patients that we all have a piece of, and really in the vein of the CCO effort to be able to do whole person centered care. So that was really kind of our first meeting of the minds. It included the directors of both ARC and On Track at the time, and then my former boss, who was the HHS director, as well as our medical director, Dr. Jim Shames, and then La Clinica. And those were the people in the room. And we really kind of spun these ideas around, like, what is our first? What should we do? How can we think different? And what are the barriers we might face? And so the very first thing was La Clinica had to get a new site approved. And luckily they did. They received that new access point in 2013, 2014. And to open a small clinic within our HHS building, which is just across the street. And we were just moving into our new building in 2015, and we designed the space specifically for La Clinica to be part of that, and then we have hoteling space where we had our community partners coming to be able to meet with those folks and offer those services and do assessments and all those types of things. At the beginning, it really was, we had 2.5 PCPs, 7.5 staff, and then a half Jackson County mental health therapists. We weren't sure how that was gonna go, so really trying to figure out the flow and then ultimately what would be needed. And then as it continued to grow in 2016, it really became obvious that there needed to be somebody kind of herding these sheep, as we all were kind of trying to stay out of our usual lanes and really be able to try to collaborate in a different way, which can be challenging. And so we worked with the CCOs and they funded that position to be able to hire, who is now Stephanie. And really, I think the whole, so my saying, my mantra is just because things are, doesn't mean they should be. And to really approach things like that, to really be able to try to figure out, just because we've done this forever, one way doesn't mean it continues to be the best way. And I really think that the Birch Grove Collaborative really embraced that idea. That wasn't my mantra at the time, that's a new mantra, but it fits in now. And certainly a lot of lessons learned. I think that at the beginning, we all realized we really were stuck in our lanes and it was hard to be able to A, let people into your lane, or B, for you to stay in yours once those pathways were open. And so each organization was really doing its very best on their own. And the challenge was to be able to figure out how we did that better together. And so I think we learned through that we can have hard conversations and manage conflicts. And in the long term, we really have created durable contracts that sustain us. So a couple of things that come to mind when I think about the difficult conversations we had. First was with what I remember happening in my boss's office with me was a challenging conversation we had with the then director of our other FQHC, Rural Community Health, saying, why them? Why La Clinica and not us? And honestly, it came down to the fact that that's where the partnership was the strongest. And they were also at this conference when we had this conversation, so it was about relationship and timing. But I didn't know that person, and so it was a challenging conversation for me, and I think it was for my boss as well, because we want those partnerships, but there was really only place for one F2HC at the moment. And then I think as the world changed and the CCO structure changed, which changed JCMH's role in the community, that was another challenging time, challenging conversations, and being able to figure out how we continue to deliver these services as the world around mental health continued to change. I think the other thing is we really all thought we understood the population we were trying to target and to serve differently because they're so underserved. And it's only through our partnership that we really started to realize that we don't really know all of the facets of these folks' lives, and we're not expert in all of the things that they need. So really being able to try to focus in on some of the data that the CCOs now had available to help us guide some of those pieces. And one of the first projects we did was we had the CCOs kind of go through their database to figure out who had diabetes and who also had a chronic mental health challenge. And we tried to look at those folks, add some additional supports to be able to help them get their diabetes under control, not just managing their diabetes, but educating them on all the parts that were important to them. And I think that that was really our first success story, using our collaboration and the data that we could now pull down that we couldn't have pulled before. And all of those folks were able to get in, be seen, get their diabetes moving forward for the management of that. And then they, they do continue to serve some of the hardest and most challenging individuals in the community. They are the primary service provider for our ACT team members, which is assertive community treatment. Those are for Jackson Care Connect members, and then people who have no insurance or on open card. And those really are the folks who kind of circle all of our systems constantly. And it's been really nice to have Birch Grove be able to hold and care for them, because it's such a collaborative model. We all know how to find them and what they need and who has the relationships. And so hopefully have been able to really make an impact on those people's lives, if nothing else, to be able to help them get the physical health care they need in addition to their mental health care. And I think another thing that we've all come to learn, not just in the first 5 years, but continue to learn, as you all know, there are plenty of people to serve. So we don't need to be competitive. We don't need to figure out who's gonna go for this population or that population, because there's plenty of folks to serve. And I think when Summer mentioned how strong our collaboration is in this community as a whole, I think Chicago is a great example of that. And just some of the bumps we've had in our community along the way, I think have made us stronger in being able to really hold these safety net services for some of our most vulnerable populations. And we'll see what all, as Summer calls it, this nonsense and including to all of the efforts we continue to make, because these are the people we really do care about. Wait for you to give me the sign. Because I know I'm rambling. But I do think that some of the other things really are, the leaders that were involved really did kind of risk everything. They gave financial risk, they, their reputation, their partnerships had to change in a way that they haven't changed before. And so really working together to be able to guide this organization together has certainly been one of those nice things that you see. So you can read the other ones, but that was the one I really wanted to highlight. It did make us think of not just the process, but each other differently and really create those partnerships along the way.
Thank you, Stacy.
And now, do I need to take over the signage, Joan?
Sure, yes.
Good morning, everybody. I'm Kim Lewison. I currently serve as the Chief Clinical Officer for Addictions Recovery Center, but when all this nonsense started, I was actually working for Clinica, and I was tasked with bringing in a behavioral health team, which we didn't really know in the beginning. It was just me. I went over to the Clinica to try to help the providers deal with the addiction that was happening. I've been at the ARC for 12 years prior to that, so my background was in addiction, and I'm also a mental health therapist. And so that was sort of where that started. And I wasn't in the first meeting, but I came in pretty quickly after that. So it's been a real love of mine to be a part of the Bird Growth Collaborative. And now I'm back at the ARC and have staff that are participating there. So I'm going to talk a little bit about some of the other historical pieces. In 2016, we had some major disruptions and changes in mental health systems. The CCOs moved contracts to options in Columbia Care. And so there were some changes happening. We were having to be flexible in that moment. We at that point had 2.5 PCPs, primary care providers, 9 staff, and a half-time options mental health clinician. In 17, the organizational structure, decision-making models, staffing levels, payment models, and all the strategic planning was getting developed. We got strategic about it. We'd been sitting in rooms, all of us, having these amazing conversations. And I started working in addiction in 1988 at On Track, actually. So I've been around a really long time. And watching this community really begin to come together, and we could see it in this Birch Grove Collaborative. Everybody was around the table and trying to think, how are we going to do this and how are we going to pay for it? All those pieces. And so by this time, we're starting to get some momentum and some structure happening, which was really exciting. In 18, the growth is really ramping up, and so are the financial losses, unfortunately. Recruitment for PCPs is a little more difficult, but it adds some stability once we get that going. Options of Columbia Care relationships are developed and brought in. All Care, La Clinica, and Jackson Care Connect, they begin to split the financial losses, a third. So that was helpful. In 19, clinics moved to South Central. Major changes in CCO membership alignment and relationship changes with All Care brought some financial struggles at that point. And then in 20, aside from the pandemic that hit all of us, we also had a huge fire here. and lost 2,500 homes and buildings. So it was a big deal all the way around during that time. And the risks shifted as well. So the risks shifted financially from Jackson Care Connect and La Clinica. So Jackson Care Connect picked up 2/3 of the financial, Clinica to the third during those times. I think the thing to reiterate what you were saying is that we survived all of this because we stayed together, because we continued to meet, we continued to work directly with the clients. That's the most important thing during this whole time, is we didn't lose any kind of hope about what was going to happen. We just kept sort of moving forward. So our lessons learned, workforce challenges require collaboration. You know, after the pandemic, the challenges were immense to try to find staff and for our sort of for the Clinica for all over. So workforce development training was a big push. We needed people to understand. I mean, there were some organizations that almost started all the way over. I think your organization was one of those where you lose a lot of people and they don't have the history, they don't have the juice for some of this work. So we had to really look at that. Addressing differences in organizational policy and culture, workflows, all of that, to truly embrace the multi-agency team-based care. And I think part of what we did was we continued again to meet, we would meet weekly, I think, as leaders in other organizations, just to talk cases and to talk workflows and all those pieces. That really helped. Shared care planning, creating alignment, philosophy, and resource allocation. What's the next slot available? You know, what do we need to do? Do we have to double book? Do we have to, you know, what do we need to do to make this work? Who has the best relationship with the patient? That was the other thing that came up. If a client wanted to go to OnTrack, or they wanted to go to ARC, or they wanted this provider, that's what we focused on, trying to help them get where they were best, where the best fit was for them. So actuarially, studies of the model of care evaluating proof of concept could inform continued investment. Was it working? Does it matter? Yes, and yes. They opened a small clinic in Aura. You heard Stephanie talk about that. Yeah.
In summary.
All right, so continuing on this journey through history, yeah, the pandemic, I mean, the pandemic. The staffing shortages in 2021, the vaccine mandates, the constantly changing rules regarding quarantine and all of that was really challenging, especially for agencies and groups like the Birch Grove Collaborative that were serving people who don't necessarily have cushy home offices where they can zoom in for telehealth and have some of the luxuries that a lot of people were relying on. So there was, there were leadership changes across several organizations. There were staffing shortages. There was all sorts of chaos going on. But during that, and during that time, we also had the Measure 110 funding that was all sorts of interesting. But it was a lifeline during that period of time. Without the funding from Measure 110, funding some of our staff, our outreach teams, our peer supports, it would have been much more difficult to continue staying the course with some of the innovative models, our emergency lodging, our staff at Birch Grove, all of those different things. Measure 110 was a huge lifeline, but it also added some additional strain in the process. There was a lot of tension with certain, trying to reconfigure partnerships and figure out how that all fit together. One of our desperate moves during that period of time was to trick people into working at OnTrack by creating the OnPace program, which worked actually.
Congratulations.
Yes. It was desperate times. We were sitting in this room. We had like 50% of the staff we needed to operate. And so we applied for and got a federal grant to create a pipeline for people who had no formal education, had barriers to college, things like that. Lived experience, had the heart but not the credentials. And so we set up this training program where you start working in any one of our residential programs is really where it started, but it's also the front desk here at Medford Outpatient. And then you can apply to be part of OnPace, and then we help people get their CADC. We have trainings on site with community partners from across the valley that are leading those trainings every Wednesday in this room. Now we're on our 8th cohort. And we have graduates all over the valley working in different places. That really supported our efforts with supporting the Birch Grove Collaborative, where we have people, it's part of their training program that they do a rotation at Birch. So that was one of our big things. There was a lot of creative ideas happening across different agencies, trying to figure out ways to attract people to the workforce. In 2024 is when Aura Options for Housing Resources and Assistance was added as a partner. Because as we know, low barrier housing options are a huge need for the folks that we're working with. And if you're trying to do whole person care, you have to think about housing. And then there was there's right now an emerging partnership with Mercy Flights for direct mobile health transport. And so the current staffing, it just keeps on. There's Columbia Care and ARC and On Track, and there's, I don't even know, the 4.2 PCPs and a clinical pharmacist, and it's all sorts of things that are going on there. The secret sauce, I fear that the secret sauce is in jeopardy, honestly, but the secret sauce is really this unwavering commitment to doing what we know works and what is best practice. With, the ultimate patient-centered care or person-centered focus, and partnerships and not getting competitive. And I think right now it's really important that stays front and center, because whenever there's scarcity of resources, competition becomes much more normal. And in our sector and serving the clients that we serve that are very much the Medicaid, people who are on Medicaid, there haven't been rate increases, there's a lot of uncertainty in the field. And so I think that, the partnerships that we have are going to be really critical to continuing to keep this going.
And now Jennifer Lynn from Justin. And do we have the slides?
Yeah, I think we should have lost.
Okay. I'll talk without the slides because Stacy printed. Thank you, Stacy. I'm Jennifer Lynn, I'm the CEO of Jackson Net, and I am constantly humbled and blown away by the people that I get to follow in this room. So thank you all. It reminds me again today of the joy of being in creative and collaborative spaces. All right. So we were here really as a supporter and as the payer ultimately, and started looking at not only a relationship-based clinic, but one that had to have a financially and logical, sustainable model. So we started looking at some of the costs that were being incurred here. And then, as you heard, it was losing money for quite a while. And so we started to look at a more rounded, the total cost of care for each one of these individuals, and where were other costs occurring for them, and what did that look like as a full picture. So to do that, we had a full data pulled that looked a year prior to engagement at Birch Grove, and then a year after they had engaged. And you can go ahead and do the next slide. And click again. And again, well, there are 4 boxes on this page. Yeah, thanks. And this shows what we found in that. There's a lot of data on here, but what I want to call out on this is that the gray bars are representative of costs before, that year before they were engaged in the clinic. And the green bars represent their time in the clinic. Really, what you're seeing here are that there were significant savings in inpatient costs, in professional mental health services, in the emergency room and observations, and in the ambulance, which makes all sense, right? It ties together. If you can go to the next slide. The next slide is looking at these expenditures over time. And this graph, you start, the first dot on the left side is 12 months before they're engaged. At Birch Grove, you can see that costs climb till their engagement at Birch Grove. And that is at the 0 mark where costs are suddenly dropping down significantly. But what I want to call out here is that those costs stayed down and trended down over time. Over the next, this goes to 22 months out past their initial engagement. So this is sustained cost. Now, the part that isn't on my slide is about the outcomes and the quality. And we often use costs as a proxy for what is happening in someone's life, how they're engaged in the healthcare system. And that's the part that I just wanted to add a little bit to here. Because I'll remind folks, there was a time at the start of CCOs when we had the beginning quality measures, and we were all as a state trying to figure out, what does equity look like? How do we measure equity? And one of the first equity measures we had was emergency room use by folks with severe and persistent mental illness. And you saw this slide here of this population, and that the ED savings were one of the earliest savings we saw. That is about health outcomes, that's about longevity, that's about managed conditions. To this day, we continue to work on quality measures with Birch Grove. And Birch Grove is in one of the highest tiers of our quality payment. That means as a separate clinic, walled off within La Clinica, Birch Grove continues to meet quality measures at a very high level. Even almost diabetes, which is one of our most challenging measures to meet for us, and Birch Grove has come within 0.3% on a very small numerator. This is incredibly difficult to do. They have also met that on colorectal cancer screening, controlling high blood pressure they continue to meet. All of our equity measures that we currently have, which are around meaningful language access and our social needs screening, Birch Grove continues to meet. Our oral health care measures, quality measures. This is a population that historically has not engaged in medical care and therefore have had exacerbated and more acute conditions that we are now seeing brought into line with our general population. And that alone is remarkable to talk about and also relevant to the sustainability of the funding that we can talk about. Thanks. Joseph.
Hi, I'm Joseph Chick. I'm the Chief Service Officer at Columbia Care. I'm relatively new to this compared to many of the other presenters. I've only been involved with Birch for about 3 years or so. And our work is, we have, like many of the other agencies, embedded staff. In particular, we have behavioral health case managers that work there. One of the things that is unique to this particular position for us and for all of our other partners is how we do our collaborative documentation and how we do all of our charting within La Clinica's system. They use Epic. I wish we did, but we don't. So we have to kind of make sure that our folks are duly trained, so to speak. We're also looking at how we can do a little better job of tracking and monitor billable versus non-billable services to really capture what's happening with all of our teams within Birch Grove Collaborative. The onboarding process that we work on, I think it's no secret that the first week or two of anybody's employment is really foundational to their experience in that employer. And so as a company, Columbia Care, we've worked really hard to standardize our onboarding processes. With this particular position, we've really aligned with La Clinica, and we do kind of dual onboarding, so to speak, where they're onboarded into La Clinica's culture as well as our culture. There's a lot of overlap, but there's also, a need to make sure that they're present and working with both teams in our clinics as well as the clinicas. One of the things on the slide that it talks about there is the wellness day. The clinica recently did a Hellgate excursion, I believe. And we were able to send our embedded case manager along with that team as part of that kind of wellness day orientation and fun activity that really helps build that cohesion and collaboration across teams. We spent a lot of time trying to really build out the front loading of the onboarding for our staff between the two locations. And then the open access model. We do open access in our behavioral health clinics. The clinic has started doing it with at Birch Grove. And what that looks like is just walk-in access. And so it really creates a lot more opportunity for people to engage in care when they're ready. I think it's no secret that when it comes to the folks that we're looking to serve, when they're ready to engage in care, we have to engage them. We can't schedule an appointment 2 weeks out, 3 weeks out. It has to be in the here and now. And so we've really worked to align our open access and availability of services across Birch Grove as well as our clinics to create that opportunity for folks as they're ready to come into care to be met in that moment.
Kiki. Good morning, my name is Kiki Park-Rose. I'm the Community Justice Director for Jackson County. And I just want to talk briefly about how we are working not only with Birch Grove, but many of the folks you've heard about or heard from around the table today. We are responsible for the care and supervision of about 2,300 adults in our community, and about 62% of those are Medicaid eligible. And so it's a high number of folks that we have the opportunity to work with. We approach things with a we, us, and our, not a me, my, and I. This isn't my client, or you can only work with me when we talk about adult parole probation and juvenile services. And this and the Birch Grove Collaborative is really that we, us, and our ability for our folks to get the best care that they can. As you can imagine, our folks come in significantly unhoused. They're returning from prison, or they've been placed on supervision in the community under probation. They have tremendous barriers, not only housing, but substance use disorder, mental health issues. They don't have identification. They don't have really some of the basic things that we know can stabilize them within the community. Some of the work that we do is we work with the livability team, which is Medford Police Department and many community partners on what we have here. It's called the Greenway. It's where many of our folks that are unhoused live. And so we collaborate not only with our A&D partners and mental health partners, but a lot of our folks that we work with have never engaged in any sort of primary care. Their primary care has been in the emergency room, right? And we know that that's the most expensive option for primary care. So having the ability to work with Birch Grove, have open access, have appointments that are available at any time that we're having an intervention or an interaction with one of our folks is really important. We have a transition center here in our community, and it's a place where we have 139 beds available for folks that are either serving a sanction or a sentence or are just unhoused. So they don't have anywhere else to live, so they come and live with us. We're a little higher barrier in that we try not to let drugs into the transition center if it happens. But what we do is when folks come into our facility or into supervision, we begin immediately figuring out what it is we're going to do to have them have everything they need when they leave us. And one of the things that we've been working on with our community justice officers who act as case managers is, where are you going to get your primary care? Where is that going to come from? We used to have health services, physical health services on site. We don't have that anymore because we're not a carceral setting, and so that's not a requirement. That's not something that's required through the county or through statute. So we've been exploring opportunities with Birch Grove to be able to come on site with us. We know that that really warm handoff between our folks, whether it's probation officer, community justice officer, case manager, a warm handoff to a physical health provider is important. Our folks are intimidated by that. Again, their experiences are in the emergency room where they go, they wait a long time because they have
a sore throat or something along those lines, and they don't have or haven't had a history of having really positive interactions in the healthcare system. The way that Birch Grove with all of the community partners that are vetted provides our folks the opportunity to be treated with kindness and respect, and be in a position that sometimes they're looked down upon for the positions that they're in. We have to hold folks accountable, and we do that too, but accountability doesn't always have to mean incarceration, right? We can look at other ways to hold folks accountable. But if we can't give them the basic things that they need, it's difficult for us to move them along in their recovery and their ability to step out of supervision into community. We are, like I said, establishing a relationship with Birch Grove to be able to come on site. They're doing some exploration. But I really just want to emphasize that Jackson, I've been with the county for about 2.5 years. The relationships in this county are incredible. And at any point, you can call somebody up and say, hey, I know we haven't talked very much, but I need help. And the person on the other end is going to say, what can I do to help you? And so that, I think, is really from the history of Birch Grove is how it started, and that we continue to have those experiences every single day. And that's a lot of folks in our community, and that we specifically live on that need the service. So I appreciate the opportunity to appear with a panel today. Thank you.
And then just a little bit about what we're currently exploring. So we currently do have a stepped integration and psychiatric support within the Birch Grove collaboration, where a psychiatric nurse practitioner and members of the collaboration, some of the staff from our partners, will meet together and do case consultations. And if somebody needs a higher level of psychiatric support, then we work on streamlined pathways to get them into our specialty mental health providers who can do that work. We also have collaboration with many other folks in our community, including Mercy Flights, who is our emergency transport organization, Medford Treatment Center, Boulder Care. We have a special project working with people who may experience an overdose in our community to try and help them, and we're excited about that project. Dr. Mann's here today, who's leading that project. Thank you. We're hoping to be able to help people engage in care immediately after an overdose at the right level of care. So that it's not always the emergency department. So they could be maybe come to Birch Grove and receive their medicated assisted treatment right away, preventing them from future overdose and hopefully helping them get on that pathway towards health, better health. We also have our local behavioral health resource network partners. So there's many of us in this room are receiving that funding, but we have other partners that we work and collaborate with locally. And then recently there have been some changes to the civil commitment laws, and we have a group of folks with Jackson County Mental Health who do those assessments with folks, and we're working on streamlined workflows that if somebody doesn't meet that level of commitment, how do we get them engaged in care? How do we get them supported? Because oftentimes they then are wandering and don't have a level of support that they need. And so we're working on that. And then Aura, we're continuing to work with the exploration at Aura, looking at more data to try and increase engagement for the folks that are there in very low barrier housing around how can we continue to support them at that clinic, but then also once they move into the community and leave that transitional housing center, how do we keep them engaged in all of our services? And many of our partners provide support on site there at Aura, and we have Deanne Cam here today as well too to speak with that. So thank you. Also, I want to introduce Ryan Bear from All Care, who's also here, and then open everyone up for questions. We have some questions on the next slide, a few that were asked of the board that we prepared and people are ready to answer, and then any other questions that you might have. So we could start with that first one if you'd like, of what aspects of the collaboration efforts do you think are universal and replicable? That was one of the questions I think you all asked. Would anyone like to answer?
Yeah. Well, I think I already kind of mentioned all of these things, and so did Summer, and so did everyone talked about the relationships and the non-compete clause, basically, like there's plenty of people who serve, we just need to figure out how we do that and do that well together. And then again, being able to have those difficult conversations with one another, always uncomfortable, always not fun, but oftentimes necessary. And also just continuing to partner among all partners. I think Stephanie just listed some new partners that we have grown into having these conversations with over time. And again, we're in our 13th year. So it's taken a while to be able to get there, but I think it also supports a lot of the other conversations that are happening in the community. So just having those tables for people to be able to continue to have those relationships and conversations. And I think it'll be even more important as we watch the federal changes. And again, just because things aren't as they should be. So.
And can I piggyback on that really quick? Just speaking to some of the, oh, sorry, this is Joseph, Columbia Care Services. That was Stacy before me.
Thank you.
Just speaking to some things that could be universal, Columbia Care is currently moving towards integrated team-based care through a SHIFT initiative funding that we have through Care Oregon. And a lot of the work we're doing in developing those teams is really anchored in what we've learned as an organization through this collaboration. So I think there's a lot of opportunity to not only, build on what we're doing, but for other organizations to learn from what's happening at Birch and implement it in different ways. So we're really kind of trying to leverage some of our experience and how we build these teams moving forward with our new care model that we hope to have up and running by next year. So very grateful.
This is Jennifer with Jackson Care Connect. I'll say, keeping the patient at the center of the design, I think was a critical part that is universal. And the timing when this rolled out with CCOs really standing up and having regional approaches towards Medicaid was also essential, and bringing the CCOs and the payers into the early learnings, the early beginnings as collaborators, rather than at the very end as simply as payers, where the yes or no conversation was also really beneficial and something I think unique but easily replicable.
We can either move through these questions or take other questions, whatever seems important.
Peter Starkey with OHPB. Jennifer, your comment kind of sparked this follow-up question of if for the other members as part of the collaborative, would not having the close relationship with the CCOs led to this being a success? Not by not having that. Like how critical, if another community was starting this up, would it be for the CCO at a fairly high level, might I add, be involved?
I'd love to take that one. So this is Brenda Johnson. I'm an Oregon Health Policy Board member and also a member of the collaborative. And what I would say, Peter, is it would have been impossible without our CCOs. I think our CCOs took early financial risk on the model. I think the whole community conversation about what a real coordinated care actually look like on the ground. I think that it was just right for it, and like the continued partnership with CCOs has been really instrumental in like what Jennifer talked about in terms of total cost of care, the evaluation of the model, the constant reinvestment of shared savings into the model itself. I don't think that other payers, other models, other plans that weren't innovative would have been able to make this happen. I mean, that's just my strong personal opinion. Great question.
I'd like to piggyback on that a little bit. I think the other element that was critical in having the CCOs involved was the data, because they could look at claims data where we couldn't look at each other's data. We're not in each other's electronic health record systems. And so without their support, we really couldn't be looking at the big picture from a data perspective, what our community needed, where they were accessing care, and maybe where they weren't accessing care, and how to shift from a higher cost of care, especially in the ED, into lower level cost of care where they really would get that individual support and ongoing support for their care.
Can I jump in on this one too? Someone's Walcott on track. I think, you know, going into the future, looking at it from a behavioral health provider's perspective, the Medicaid fee-for-service reimbursement model is going to be the death of innovation and best practice, because we know that having open access makes a huge difference. Team-based care makes a difference. If a client has an existing relationship with the ARC, my staff are expected to send them to the ARC. We get reimbursed based on a treatment plan with a diagnosis, with a billable service, with a note that is not written in La Clinica's system. So the whole model and the CCOs and OHA and all of that, especially as funding gets more and more tight, and we're all having to look at ways to sustain. The fee-for-service model is going to be a really critical thing to talk about when talking about setting up systems like this.
Yeah, this is Jennifer with Jackson County. I think you hit on that next question. What are some of the barriers that we create inadvertently in our system? And I know you talked about doing dual diagnosis care as well, which has been a barrier historically for us when we split mental health and substance use into two entirely different conditions. I do want to speak, it's my pride in being somewhat a part of this work is tremendous, and the period of shrinking resources is very real. We know the federal changes. Dr. Huffy started us off with federal changes today, but even just at a state level, we have been facing double-digit cost increases for several years now, and only single-digit rate increases. And so as that continues in the CCO space, we look increasingly at our quality dollars to fund this kind of innovative work that's outside of the fee-for-service model. And we know that there is a shrinking of the quality pool from OHA as well. So I just have to say that it is this kind of collaboration that builds on relationships outside of that competitive environment, I think really is best for our staff, our agencies, and our community members and patients. And there are significant barriers ahead of us to maintain, let alone build. Any other questions? Action.
I have one question. Hi, this is Dr. John Mann from Jackson County Health and Human Services. You know, I find your data really compelling that you were able to present the 12 months pre and then the engagement data on costs. Thinking about, you know, reductions in expensive care, ER, ambulance services, and how those reduced. And also thinking about the public health implications there. Right now, we have really stressed ERs, very long wait times, very, very high leave without being seen rates in our area. This solved a lot of problems, financial as well as quality of public health. What other areas have you identified other areas in our community that represent similar opportunities to reduce high cost care, increase access through expanding this kind of innovation? Is there anything else out there that you've seen that you're thinking about? Because this is great, very exciting.
Well, again, we are following the lead of so many, right? So the innovation is occurring, and we hear about it and figure out where and how to support. I think anytime it involves, we are seeing other spaces that involve embedded staff in different settings outside of their own organization. And that seems to be a really critical piece of outcome supported results, right? Because it's about more handoffs, it's about helping patients cross bridges and barriers in our system that otherwise are pretty significant. So that wherever we see that occur. And when we see work that is focused specifically on high-risk populations, and for us, that often means those with significant behavioral health diagnoses, that is where we really see an opportunity. So that has involved things around psychiatric care, that has involved things around the partnerships with Mercy Flights, helping target the way we do outreach and engage folks in care. Yeah. And it is always hard to sustain cost savings when you're just trying to manage what you currently have to spend. So that is always the pressure in any kind of fee-for-service-based system that we ultimately.
Tony, I see your hand up. Go ahead.
Yeah, thank you, Kristen. Wow, what an exceptional model. And thank you so much for sharing today. A lot of great learning and opportunity to observe what you have constructed and built up in your community. And I think I'm reflecting on our review of CCOs 2.0 and just the collaborative effort and seeing what has bolstered this community and built it up. I was curious, a question, the standout to me in the feature that seems to be functioning well in this community is the relationships and the communication. And I was curious how that has been constructed. And is there a central area where one of the clinics or one of the organizations, I need to get this patient over here, I need to get this client here, I need these services, or is it just getting on the horn and phoning over to a respective part of this collaboration? And is that something, if you haven't already done, is that something you're looking in the future to?
This is Stephanie Lyon, Behavioral Health Collaborative Director. I think that we do have the embedded staff at the Birch Grove Health Center where a lot of day in and day out care coordination happens just on the ground immediately in real time, constantly. To walk in that clinic and see it happen is I call it magic. Because we're not leaving voicemails and waiting for somebody to call you back, and people are getting connected to care quickly and in real time. And then we have other partners that may not be embedded, but we do have those working relationships that are there. We have meetings that we see each other at regularly and things like that, that those communications will happen. It's not uncommon for the teams, they have phone numbers right there to dial the right people at the right time, and they know how to get a hold of each other. We are working to get some of the embedded partners integrated into Epic. And then they'll be able to chart in Epic, but not their full charting, just something that gives us a look at what they're doing. And then they can also communicate with other team members using the Epic features in there. So we're working on it. We also have regular meetings. I think the meeting structure is important. So we have the embedded staff and their direct supervisors meet with the clinic manager once a month to just discuss any workflows that need to be improved or staffing issues. And then we have a steering committee meeting once a quarter with all of the executive leadership to navigate any barriers or systems in care and talk about those things that are happening in our community.
Wonderful. Could I ask, do you have case management in these settings?
Yes.
And I'd just be curious, what kind of, is that overlapping between institutions and organizations?
Yes, this is Stephanie again. At the Birch Grove Health Center, we will have embedded case managers from both Options and Columbia Care, two specialty mental health organizations, plus our substance use disorder providers, ARC and On Track, will be all working together in one team room with the behavioral health staff from La Clinica. And so that's how they all are just navigating and working together daily to coordinate care.
Remarkable. You guys are doing exceptional work. Thank you.
Thank you. And this is Stacy with Jackson County. I just would add to that, that many of the folks who come into Birch Grove already have established case managers that exist within other systems. So that coordination piece is really important so that we're not being duplicative in effort or cost, but also really making sure that the case managers who are dealing with those folks day in and day out have the information that Birch Grove has to share, and that we're doing that in a cooperative kind of way. That's another benefit to this model.
I also want to add, Jennifer, that I think historically in this county, there have been good relationships, but a fear of sending your best staff out to some other setting because you might lose them to that other organization. So there was this idea, right? Like, don't send your best ones there. And that undermined a lot of collaboration efforts. And what's happening here is really the best staff are the ones in the room Stephanie was just talking about. And there's enough trust within the organizations to be able to take that risk. Which sometimes I'm sure hasn't worked out, but has always been to the patient's best interest, and these organizations.
Melina, I see your hand up.
Hi, thank you. This is a remarkable model, and thank you all for being here and sharing. I wish it could be reproduced in every community in Oregon. But two things that I really enjoyed hearing about and stood out to me, and two small things that can be, I feel, easily reproduced in most communities is one was the workforce pipeline. I heard that people who had a lot of heart and no education, and you took them in and started them out on the ground floor and provided education and moved them up. I thought that was remarkable. The second thing was I loved that how you treated overdoses. Not all overdoses need to go to the ED. Some could go right to the SUD clinic and start MAT if that is appropriate for them. And that saves resources. And I think that's another great program. So through this collaborative, there's so many wonderful programs that are happening, and I applaud you all and thank you for sharing.
Standing.
This is Bill, I'm a board member. I had a question. I saw the slides, there was a discussion reference to shared savings, reinvestment, value-based payment. I also heard Summer say that Medicaid fee for service will be the death of our model. Could you explain a little bit more about how the model works, how money flows, and what how that supports you, doesn't support the care model, how it supports you, doesn't support the patient outcomes, and what could be done to improve it?
I can start with that. This is Jennifer Jackson Care Connect. And I think one of the slides talked about the evolution. So we started out just supporting some of the collaborative work, one of the physicians. La Clinica was losing money. We ended up saying we'll share some of those losses. We didn't really know what was most logical, but we started to wade in that space. It wasn't until we had the analysis done that I shared that we were really able to start thinking about value-based payment. But the totality of what you've heard today is really a mix of many different kinds of things. So we are paying the substance use providers, the mental health providers, basically fee for service. We have different value-based cares programs with each one of those. And so we're paying all of their touches and the supports that they do for these patients through our direct relationship with them. Most of the innovation has had to occur on the primary care side because it has been a very expensive model in primary care to create this kind of open access to pay and support the staffing and often expensive staffing required for that. And so we have now moved into paying an additional per member per month on this model. It is not cheap. I think we are somewhere in the $40 space for that, and that is what causes the challenge ongoing when we're under cost pressures. We have increasingly looked at our quality pool dollars because this clinic really is helping us meet quality pool measures. And so we move those dollars back into sustain. Does that answer your question?
It's helpful in understanding how it works to this next for service at PN. So, is it working? And could it be better? How? That's a big question. But we're looking for just.
Yeah, maybe the providers have a better, it's working and it's fragile, I will say, because of the pressures we are under. But maybe other providers from your side have a different response to, is it working?
This is Summer Walcott. We have historically found grants to fund our staff that are staff at Birch Grove. Because we can't bill enough Medicaid fee for service to even come close to paying for them. And so as the whole system gets more and more constricted, and grant dollars are, we have to choose who we can staff, what we can staff, what we can afford to do. It's hard to say how things are gonna play out. I know our staff members, I don't know about, I'd be curious to hear about you, Kim. Ours were funded by Measure 110. In this recent funding cycle, they deprioritized funding organizations that fill Medicaid. So those funds are increasingly going to other types of organizations. And so it's really tricky to figure out how to do that and how to continue to do what we know works with reimbursement that doesn't actually pay for itself.
We're in the same boat. We send peers, primarily peers, the certified recovery mentors. Some of those folks do have their KDACs as well, but they function as peers. It allows them to do assessments and that they want there. But we either do it out of the goodness of our heart, or if we have $110 to do that. I'm a deep believer, so is our CEO of this project. So in some ways, it feels like expensive economy to not have them there, because they are our patients, they are our clients as well. But in the summer, it's starting to dry up, and where we're asked to, where our community partners want us to go to help, we want to go for sure. We've got to have a way to pay for it. That's a struggle, or will be a struggle. Yeah.
This is probably not enough money. I'm sorry, this is Bill Kramer.
Louder.
Is the problem not enough money or the structure of the payments? It's kind of what
No, it depends on the day. It's more of that. So if a peer is sitting at our shop, they have a constant flow of clients coming in. When they're at Birch Grove, you don't know who's going to walk in the door and what the need is going to be. And because there's a whole community group there, it may be better that Summer's person see that person as opposed to my person, which is they just kind of drop their mantles where they work in those cases. So they're just not able to generate quite the amount of billables as you can in our regular environment. Yeah.
And I think not enough. You're hearing Measure 110, you're hearing Medicaid pressures. I think it's both.
This is Kirsten Isaacson with the board. Just to be clear though, like when we look at that total cost of care chart, to piggyback off Bill's question about like, is it the big picture money or the little picture money? And I'm hearing both. But that total cost of care chart makes it like, if this work is not happening, the same people, there's a much larger expense that will be incurred elsewhere in the healthcare system.
Yeah. And again, expenses are a proxy to poor outcomes as well. Right?
Yeah.
So it's impacted lives.
And I feel like that total cost of care is an excellent, kudos for doing that study, it's so important. And there's so much more that could be measured from the benefit of that. I just think about access to the ER that is then opened up for the other community and other emergency needs. And I think about staff in all locations staying in their positions and continuing to serve because they feel more effective in where they're at. And anyway, total cost of care is excellent. And then there's so much more benefits that are happening that are not included in that large measurement itself. Peter.
I have a comment and I have a question that I feel like I know the answer to, but Peter, Starkey, OHPB. Just kind of the comment, I think that we've been talking about this at the board level of, and having been in rural settings for work and now metro area, that we can learn a lot from rural areas and rural communities because you gotta find a way. And now having transitioned from a rural setting to metro setting, where one of the things that boggles my mind is that 10 years that this has been functioning. 12 years ago, this wasn't even innovative, it was unheard of. And conversations that I'm involved in my job at the metro area, like they're still at the, no, we really shouldn't be competing all that often. Oh, we should really find a way to work together and do this thing. And just kind of recalling that to our rural communities are incredibly innovative beyond even the word in. Because 12 years ago, this was it. I'm very impressed that you sat in a hotel room and came up with this 12 years ago. And then the thing that kind of spurred, I think it was summer, a little bit of combination of a lot of sort of the employee base of bringing in those with lived experience and sort of building them up. That also makes me think that as you build those people up, they're no longer on Medicaid. And is there a private insurance involvement at all in any way, shape, or form?
If only the
Not yet. Yeah, I think that's one of the things that, and since I work primarily with people that have lived experience that go from, and we focus a lot on OHP and for good reason. But we have a lot of people that come off of OHP because they're doing well. They're getting gainful employment and they're pulling their lives together, but it's still that incredibly fragile moment where they lose access to a lot of innovation and a lot of systems and care that was available before. And I'm just thinking about the upstream versus downstream where if there's any way to be able to support that at the OHA level of how do we ensure that, yes, we have our most vulnerable, but we also have those that are just teetering on the edge and could fall back into the Medicaid system and into unemployment and disability and all of these things.
Kim Olson with the Addictions Recovery Center. It's interesting that you bring that up. When people start to get successful, they get punished by getting terrible insurance or no insurance. I mean, right now, our private insurance doesn't pay for it until now we got a minute come back. So we don't get any support from. I mean, OHP is gold standard, and that's what we all should be on.
This is Stacy Brubaker again. So, we as a community mental health programs across the state have on a regular basis tried to get insurance companies come to the table to talk to people just about how they might help fund the crisis system, right? Because it's not just OHP folks who serve the crisis system. And historically, we get one, that specific source. Nobody else is required, expected, I don't say forced or coerced, but we've only ever had one
willing partner to even talk about, and that was really specific around children's crisis response, because there aren't any residential programs for the most part for kids in this state. And so that's the most traction we ever got, and that kind of died on the vine because they didn't want to be the only payer. And so, you know, I think these conversations have lived and existed forever about how do you force, mandate, require, whatever word you want to use, to have those insurance companies who are some of the biggest money makers in the healthcare system contribute back in, like CCOs do with the Medicaid population. And I don't know whether that's anything anyone can necessarily change or require, but I think until something gives in that space, it's always gonna be the nickel and diamond, robbing Peter to pay Paul, looking to the state or to Medicaid dollars to really be able to fund those pieces. And the other part where people kind of age out of is when they switch to Medicare. There are so many services that Medicare just doesn't pay for. So folks at Birch Grove, certainly folks that we serve as they change into Medicare, it really restricts. And again, we eat a lot of that because we believe in the care, but that's not a way to have a sustainable model. The other thing, if I segue to a different conversation now.
Sure, we are going to wrap up this portion shortly.
So back to the other slide asked about like future collaboration or whatever. We as a community have been really invested in having ongoing conversations in anticipation of the carceral benefit starting. And we were ready, man. We had a plan, we knew what we were gonna do. And then it just kind of all died on the vine. And I think there are pieces of that we continue to kind of figure out how we do using one of the opioid settlement dollars that the county gets, not necessarily the dollars that we get from the state. But again, just speaking to the commitment we all have and those folks who come in and out of the criminal justice system are folks. Those are people who are jailed because they're homeless, because they have a substance use disorder, because their mental health symptoms are acting up. Those are our peeps. And so we're gonna figure that out. I also oversee the jail contract for medical services in the jail that the county pays for out of general fund dollars, which when you think about where else those dollars could be invested, if we just had a way to get reimbursed for all the services that are happening in the jail. And so again, I realize that's not new, but I think if there is anything from a state level to really try to advocate for that population to be able to keep their health benefits so that we all can continue to provide and wrap services and supports, then that's another pipeline. You have the ED, but you also have the jail. And so just that's kind of my final thing about like, if you could do anything, you know, or advocate for something, I think we need to continue to figure out as a state how we try to address those issues, because those are dollars that, you know, the county currently invests in that place, not saying they would invest in somewhere else, but at least gives us some more about how else we can use that.
And I just, Kiki Parker with community justice, and that includes juvenile detention, right? It's part of the carceral setting, and that would be Medicaid waiver. That's a very vulnerable population as well as the adults in custody.
Well, I want to thank each and every one of you for joining us this morning, sharing earnestly about the history of this project in collaboration, and all the myriad of people who aren't at this table, but who are touching each and every part of this work, because I know each of you represent a large team of people, and so thank you. Thank you. And I really, I think there's a lot of, it's like a mix of courage and really like value driven focus that we've heard about today, and it's just that how you have built a model that is the epitome of the person centered, is thank you for sharing it. Thank you for doing it. And I think you've given
health policy board a lot and the state a lot to think about, to consider as we move forward into all the things that will come. But really appreciate. So, thank you.
Thank you for coming to us.
With that, we will transition into a few moments of public comment and testimony, and then we will have a break. You are welcome to do as you have to do it. You're all busy. So the Oregon Health Policy Board welcome and deeply appreciates public testimony. It is one of the most powerful ways we demonstrate our commitment to profound listening and learning. Deep listening means that we will not respond to what you share, attempt to fix or resolve the question and concern during today. We will also not interject, correct inaccurate comments that are shared as fact. We will, however, bring it fully into our awareness, understand it as an important consideration for our work, listen with careful attention, respect, and honor that you deserve. We want to acknowledge that time held in our meetings to hear public testimony is meant to provide a voice and perspective from that individual and is not a representation of the Oregon Health Policy Board, its members, or the Oregon Health Authority. Each presenter is given 2 minutes to share, and in the event that doesn't feel like enough time, we encourage you to provide written testimony, which we commit to reading. To help keep us on time, we'll start a 2-minute timer for each commenter. We kindly ask that commenters conclude their presentation when the timer is complete. Please know that written and verbal public comments will be reviewed and discussed following each meeting by the board chairs and staff for an appropriate next step. Andy, I see on the screen, turn to you in a moment. I do want to just highlight written comment that is in our packet from both Bob Santa and Michelle Serengeti. And Andy did written comment and is here to share some verbal comment with us today too. So Andy, begin when you're ready.
Great, thank you so much. Hi everyone, my name is Andy Walsh and I serve as co-chair of the Health Equity Committee to the Oregon Health Policy Board, as well as Senior Health Policy Advisor for the Children's Institute. I thank you for the opportunity to provide this comment today around continued threats to Oregon's goal of eliminating health inequities by 2030 by providing robust access to care, but particularly around ensuring network adequacy. We see threats to network adequacy are persistent across the public and private sectors and are hitting OHA's identified priority populations the hardest. Most recently have been threats to a robust network of gender affirming care for transgender populations. As reported in the past week by Basic Rights Oregon, COIN, and others, Kaiser Permanente has announced a nationwide pause in providing gender-affirming surgeries to transgender young people under the age of 19, including at its Oregon healthcare facilities. Kaiser Permanente representatives cited the federal legal climate for the policy change, as hospitals and providers across the country are under continued pressure from the Trump administration, including receiving subpoenas from the Federal Department of Justice. The pause will be effective starting this month, August 29th, 2025. Kaiser has stated that all other gender-affirming care will remain available. However, this is another concerning advancement in an environment of fear and intimidation for providers and health systems, as well as young patients and their caregivers. OHA has a particular need to provide guidance on this issue because Kaiser is one of the healthcare providers for Medicaid recipients in the Portland metro area for Care Oregon. Continuing to lose access to providers will exacerbate existing network adequacy issues, which House Bill 2002 explicitly directs OHA and DCBS to track and ensure. Without clear alternative guidance or support, additional providers may continue to follow the lead of the federal government and leave more patients in Oregon without access to life-saving care. And I urge the members of OHPB to request clear guidance and proactive support from OHA on these issues. Thank you.
Thank you, Andy. With that, we will have a break. We will rejoin at 10:40. Yeah, thank you. I just needed your supervision.
Yeah, unmuted.
Deckers, like, where are you? Ready to start? The policy board. Are we what? Let me know.
Yeah, we are unmuted and live.
Well, welcome back, post break, to the Oregon Health Policy Board meeting. Members are coming back to their chairs in the room, but everybody is here listening. Next up in our agenda, we are going to revisit the guiding principles for Oregon's healthcare market oversight program, also known as HICMO. The Oregon Health Policy Board previously approved these guiding principles in October 2021. In a few years, and that was just prior to the launch of the HICMO program. So today we're joined by Zachary Goldman. Hello, Zachary. To receive a program update on the healthcare market oversight program. And then we'll have time for the board to consider if there are needed changes to these guiding principles that were previously. Zachary, thank you for joining us remotely, and the stage is yours.
Great. Thanks, everyone. Hi, good morning. I'm Zachary Goldman, healthcare cost economist on the Health Policy and Analytics team. I have a few slides that I'd like to cover, but I really want to dedicate most of the time for a discussion among you all. So allow me just to get through a handful of slides. Let's go to the next one, please. So the Healthcare Market Oversight Program, we review proposed healthcare transactions, business deals, to make sure they support statewide goals related to cost, equity, access, and quality. And you'll hear about those 4 domains throughout this presentation. Generally, HICMO, or the Healthcare Market Oversight Program, aims to promote transparency. We publicly post notices and reports so that communities have information about planned transactions so they know about it. We aim to support statewide priorities such that healthcare deals support goals related to affordable healthcare, eliminating inequities, a lot of topics that the board has discussed recently. And the program monitors and studies impact. So we track deals in Oregon and evaluate how they may affect people. We produce reports after the transaction occurs to provide some visibility into how things are shaking out after a given transaction. Let's go to the next slide. So as Kirsten said at the top, back in October 2021, the Oregon Health Policy Board approved the framework for analyzing proposed material change transactions for the Healthcare Market Oversight Program. And here's just a picture of that document, and Tara just linked to it. So this framework was initially used by the Healthcare Market Oversight Program in the development of the program's analytic framework. And the Oregon Health Policy Board's framework really grounds the program in terms of how it approaches each transaction review. That's why this framework is so important for us. Let's go to the next slide. And in terms of the Oregon Health Policy Board's role, so the statute actually that creates the Healthcare Market Oversight Program specifically references the Oregon Health Policy Board and directs the Oregon Health Authority to adopt rule criteria approved by the Oregon Health Policy Board for the consideration of requests by healthcare entities to engage in these transactions. So the approval of the guiding principles and the framework fulfills OHPB's obligation as required by law. And it provides us clear strategic guidance to OHA regarding how to approach these transaction reviews. Let's go to the next slide and let's dig into the actual framework itself. So there are 6 guiding principles that the Oregon Health Policy Board discussed and approved. The first was focusing on improving the health of people living in Oregon. Secondly, to ground all analyses in the impact to health equity. Thirdly, look at the impact to equitable access to care, specifically essential services. There's also healthcare quality and cost to consumers, patients, employers, and other purchasers. Next, meaningfully engage the public in robust and transparent process, which may include the creation of review boards, also known as community review boards. And lastly, use resources wisely and collaborate with the Department of Consumer and Business Services and the Department of Justice when applicable. So those are the 6 guiding principles that were previously discussed and approved. Let's go to the next slide and talk about the 6 concepts that the Oregon Health Policy Board discussed and approved back in 2021. The first focused on health equity and including the entity's demonstrated commitment to addressing health disparities and inequities. Secondly was equitable access to essential and other services. Third was healthcare quality for all people living in Oregon and the cost to consumers, patients, employers, and other purchasers. Next is the demonstrated commitment to the Sustainable Healthcare Cost Growth Target Program. Next is market share of the entities involved in the transaction. And lastly, the financial stability of the entities involved in the transaction for situations in which there's an immediate threat to healthcare services and the transaction is urgently needed to protect the interest of consumers. So those are the 6 concepts that the framework spells out. Let's go to the next slide, please. So there's additional feedback about the HICMA program. We anticipate hearing some thoughts from Oregon Health Policy Board members today. We envision that we're going to hear some thoughts about the program at upcoming public listening sessions that the HICMA program will host. We imagine we're going to hear public comments throughout the rulemaking process, which will be occurring this fall and winter. Now, it's important to note that some proposals that folks have may require a change of state law. Other proposals may be addressed during the rulemaking process, and other proposals may be incorporated into sub-regulatory guidance documents. So it really just depends on the nature of the comment or the nature of the suggestion. Let's go to the next slide. So now I really wanted to just paint that picture and open it up for discussion, because now's a good opportunity for the Oregon Health Policy Board members to revisit the framework and the guiding principles before we begin rulemaking this fall. So broad question, are there changes to the framework or guiding principles that you all would like to propose? And just by way of timing, OHA requests that the Policy Board approve any changes to the framework or guiding principles no later than the September meeting, such that we can have those solidified as we embark on the rulemaking. So we have that grounding, that foundational grounding. I think we'll pause there. I have a couple more slides, but that's more kind of wrapping it up and timelines from here on out. But Kirsten, I'll pass it back to you to lead a broader discussion among the board members.
Great. Thank you. This is Kirsten. Thank you, Zachary, for that overview and for both your invitation, specifically around the framework and guiding principles, and also understanding that all feedback might not fit into those specific buckets, but that things can find the lane they need to be in. So with that, I would like to open it up to board members to hear kick off this discussion, hear your thoughts and feedback on the framework guiding principles. Maybe if we can focus on those in particular. We do have like a discrete time to task that we don't have to finish today, but we do need to finish by next meeting around those in particular, and then the program more broadly.
This is Brenda Johnson. I'm curious if maybe I could get grounded again on board's oversight responsibility for the HICMA program and what decision-making authority we actually have relative to this conversation. That might be useful for me to as we warm off the conversation.
Yeah, Zachary, do you want to go, or actually, Zachary, but maybe someone else is controlling the slides. Can we go back to that slide where our role is defined in statute? Thank you. Zachary, do you want to answer this question?
I apologize. I couldn't hear all of the question. Can you repeat it?
Sure, this is Brenda Johnson again, and my question, the root of my question is about this board's decision-making authority and how, what the September decision might look like, what we actually have scope to approve, and what is within the agency's purview.
Yeah, happy to answer that. So the Oregon Revised statute here that we're looking at, it really focuses the Oregon Health Policy Board's role to look at the criteria. And that criteria that we kind of talked about on the next slides, that really kind of leads then to the kind of the 4 domains that the Healthcare Market Oversight Program has embraced: access to care, quality, cost, and health equity. So the framework that initially was discussed back in 21 really does paint that picture and kind of root all analyses in those 4 areas. It also mentions some of the other statutory required things, such as solvency considerations when an entity is facing a potential insolvency. So it's kind of, I would say, it's those 4 domains plus other things referenced in the statute. In terms of the overall Oregon Health Policy Board's kind of requirements, and I believe Dr. Johnson, is that where you're going?
I'm just looking for like what our general scope of decision making will look like for the board, you know, and I guess I'll just follow up with a little clarifying point. You know, for the board to approve general concepts, and then once it moves into rulemaking, the interpretation of that guidance and concepts is always subject to a lot of discussion, I guess. You know, so how I'm thinking about this is how specific is this board going to be with its future recommendations? And because in rulemaking and in the other processes that follow, that's where the details really happen. So I'm trying to level set my own expectation of the request of the board to update the guidance. Because once it moves from this board, it often has life of its own. So that's what I'm really trying to get at. Yeah.
Sure. Yeah, so I mean, I interpret the language here, and I think it aligns with how the board interpreted it and kind of implemented it back in 21, was to kind of discuss and then create a evergreen document that really established the overall principles of the program. Kind of what are the priorities that the program shall embrace as it's reviewing each specific transaction. That's kind of how I think that's how the in 21 the members of the board implemented that particular statutory charge.
Yeah, and I think I recall it as a little bit of us identifying important touch points or North Stars to guide the implementation of this program, but to not it left space for agency and the BRAC to build out the details.
And where legal review may be, you know,
Yes.
intersecting those very principles. So like the concept of transparency is an example.
Yes.
Where, you know, what I think the board originally envisioned didn't manifest, you know, entirely in the processes themselves. And so the question for me is, if we revisit as a board the conversation of transparency, and how to integrate public comment or community feedback, and how that integration of community feedback is drops into some material change. You know, those are the questions that I'm just sitting with. I don't yet understand the pathway to resolve. Yeah.
This is Bill Kramer on the board. I'm really glad you raised that question, right? Because I think that's an important issue for that's what is our whole. And I think there's several other layers. The Dockery's response referred back to the original Canadian legislation for the program. That's one level. We need to fulfill that. But I think there's also in our broader charge oversight for our programs that we should have an ongoing process. Exactly what that looks like. I think that's kind of what you were getting at, and that we should make sure that as things are implemented, both in terms of rules, regulations, and process for us to review specific transactions, we should ensure, we should be monitoring and ensure that that's being followed, that the guidelines that are set in place are being followed, or that spirit and letter. There's a broader level too, is that it's not just about the HICMO program. Right? The HICMO program is one part of.
Hey, Bill, can I interject just for a moment? I see Zachary putting in earphones and I find myself having a little difficulty hearing. I think Melina is sharing as well. Is there a way we could move the mic closer to Bill just to hear a little better?
I'll try to speak up too, Tony.
Thank you.
Whoever else is on the listening in. Do you need me to repeat anything? I'll try to recap quickly. Several layers. One is the enabling legislation that about what our role is in setting the guidelines. I believe there is part of our broader charge as Oregon Health Policy Board reviewing and monitoring the implementation of our program through rules, regulations, and process of specific transactions that we need to ensure that that's being implemented in a way that's consistent with the guiding principles that you articulate. I think there's a broader issue to those. HICMO is part of Oregon Health Authority's overall programs and the state's efforts to improve affordability while ensuring equity, equality, and access. And so we need to be looking at the HICMO program in that context. How is it contributing or not contributing? Or how do the elements that we need to drive affordability, how does that affect the HICMO program happening? Part of that larger effort to improve affordability, quality, also improving equity and access. And so we're still on a kind of conceptual level. I think basically turned into something specific, but I think there is to the role. That's my perspective. You can see if others on the board. I think that makes sense to give us a blueprint for clarifying what our role is. Who has to see?
I think it just need to work on your skin close.
This is Kirsten. I wonder if I think, or for my years on the board, our relationship with HICMO is still somewhat unique, and HICMO is a young program, so I think that's part of why it feels different than other established programs that are unrelated to the board exist and continue. And of course, this program is independent from the board as well. But we have this role in the rules. Tony, I see your hand. Yes. And so I wonder if we just might have to struggle a little bit in defining that, and we might have to hit the wall to know where that boundary lies in our role.
Yeah. For me, it's the question about like how policy level, kind of high bar picture versus the specificity of improvement actions that we see within the program itself. And so what I'll be wrestling with over the month is exactly where our set point is, because we can see there's improvement in any young program to your point. And we can also say, are we still aligned and verifying the guiding principles that put it in place in the first place? Or is that refinement what's actually being required of us now? You know, so that then as the thing gets implemented again in its next iteration, it has more kind of line of sight, you know, vertically into what that intended, you know, purpose actually is. So
I think it's fair to share regardless of what it is, and then I think we'll ask for partnership from Zachary and Sarah and team in maybe helping us parse for that. I would say don't hold back. Tony.
Thanks, Kristen. Yeah, Brenda, I really appreciate your question, and it's something that I believe we've all wrestled on the board, and in kind of the space of where OHPB and I came on post, the rulemaking and the passage of law in 2021, and thinking, where is this tool being an effective tool? It is approach that the state is taking place for some of the attention that's needed, which Bill highlights, which is regard to access to care, affordability, making sure that our networks are appropriate, and with consolidation, how does that impact the quality of care and health outcomes? I really appreciate just the conversation. I think we set this out in October of our last retreat, just a reflection and really a point in time to evaluate as this tool has been unveiling over the last 4 or 5 years. And when I look at interventions and I look at tools that we use, when we come to these guiding principles, I think it is a space for us to look and provide that North Star. Are we seeing the outcomes? Are we seeing improving of health of people living in Oregon with HILCMO? Are we seeing the analysis of health equity, and what does that define for us? And so actually, I have more questions, for the HICMO team. And I think there's some learning to say, where could we help their work in this iterative process? They have learned a tremendous amount. Each single review, I would argue, is probably different. There are some flavors that are coming forward as saying there's some similarities between one material transaction versus another, but they all are very different. And I'd be really interested in hearing more from Zachary and the team. What are the questions that you've wrestled with in saying, how do you define the impact on health equity? How do you define the decision-making of do you allow it to proceed or not? How do you define how you set up a community review board? Is 6% or not 6%, about 10% of transactions that we've reviewed so far, did it necessitate a community review board? Do we need to have more community review boards? I'd be just curious the questions in surrounding that. The reflections, I think that when we look at transparency, that's a lot of the observations that I've heard from community members. And I do wonder in the setting as we move forward in the next couple of months, I worry a little bit about us providing too much commentary when we haven't heard from community. I think that's a really important space for OHPB to hear from community and to hear from health systems. How is this program working? And before we define our comments, as we would do in other reflections, we would want to hear from community. So I guess one standout to me is I'm not so certain that we'd be able to get back the quality of information we want by September, Zachary. I think that might be something we might have a conversation about. But I think answering the question, is this program reducing costs for Oregon? Is this program maintaining central services? And what are the counterfactuals whether a transaction were to be denied or not? And I guess I would just make the observation that of the listed of 55, we haven't seen a denial necessarily yet. And I just wonder if that's an observation, and is that what we want to see, or is this a program that could be more aggressive or less aggressive? I don't know the answer to that, but I think this is a time for us to examine those questions.
Go ahead, Tom.
This is Bill. I just wanted to follow on something that Tony raised. I have questions too about whether it's realistic and appropriate for us to try to force a decision on what the framework guidelines should be by September 9th. In particular, I think what's missing from that is public input. And it seems to me it's a little out of order. Maybe I'm missing something, but it's kind of out of order to have us kind of from top down either endorse existing guidelines or modify them in some way without public input. So I would suggest that we modify the timeline to do the public input first there's no structured way, asking some of these good questions that are coming up here and then have a process by which the health policy board reviews those, their discussion with the HIPAA and OHA leadership. And then we modify or endorse, modify the guidelines that could then be the basis for a rulemaking process.
Support that, sure. Zachary, I know that you guys are, this was step one before you head into rulemaking. Talk to us about the implications of this.
Yeah, so I think we have time. The one more kind of time pressing issue is, and we've been really public about this, at the next rules making process, we will implement a change to our underlying fees that we charge the entities to support the program. Notably, the statute that created the program also specified that the program shall be funded by fees. And now that we've had a few years under our belt, we know approximately how many transactions we're likely to see in a given year, the size of the entities that are engaging in those transactions, which the statute kind of references in terms of one of the factors for determining how large the fee is. So, so we do want to do this. We do want to do the rules process to update other kind of operational components as well as the fees. But you know, I believe there is time for sufficient engagement here. So I think that's fine.
And it kind of, this is Claire role with OHA, and I will just speak to, I guess, a couple different things. I do want to reiterate the importance of being able to update the fee structure. You know, at the current moment, we are doing a lot of work related to transactions that are not covered by fees. The team conducts pre-review conferences before filing, before comprehensive reviews. Right now, there are no fees for those type that work. We are also not receiving fees commensurate with expenses we have to DOJ. There's a lot of questions about that were already raised around, for instance, how we and how the program reviews information that entities deem confidential, and how do we promote transparency. All of that depends on working really closely with our DOJ colleagues, because we are not making those determinations alone. And so the fee updates are really essential to being able to actually operate this program. And that's why there is some urgency to moving forward with rulemaking. And the rulemaking process itself is public engagement. It is an opportunity to be able to hear from the community in those forums, and to continue to review the feedback that we've gotten during community review boards and on each transaction. And so I do think the program has a tremendous amount of public input already, and perhaps what we could think about is how to best synthesize that for the board to consider, because I think the framework itself has been essential and will continue to be essential in how we conduct rulemaking. But the statute only gave us so much direction. That's why rules are important, and that is why updates on a regular basis, once we have, now that the program is actually operating, we understand what our programmatic needs are, and we understand, again, what the expenses really are. There is a need to update this program, and which is why we would like to move forward with rulemaking in the fall.
Great, and just to be clear, this is Kirsten. To be clear, there are two levels of feedback here versus the framework and guiding principles set by OHPB that create framework is appropriately named for OHA to then implement the program and adopt rules under, and then the rules have a rules advisory committee public process that comment on the draft rules of that. Okay.
That's right.
Go ahead, Tony.
Well, really appreciate that framing too, Claire, and really, as I've said many times in calls, really want to support the great work that HICMO is doing. Fundamental to um, giving due process to review the merits of these transactions that are taken across our state, and really some great outcomes. Really some tremendous investigation, engagement across departments and really value that work. I think just my interest in this space too is also to your comment to making sure that it is equipped, that HICMO has the staff, the resources, the funding, with the breadth of information that needs to be reviewed. And so, I guess that's a space where it doesn't seem we necessarily weigh in. And this is the tension I feel where I think we can voice support because it does come back to affordability. It comes back to access across the state. That's where I think Oregon Health Policy Board should apply pressure to make sure that this program is able to be intentional and have the outcomes that we want to see with it. I guess just some of the other things, there are some other specifics that I'd be curious about, and I guess we'll just provide that in written comments to the team in thinking that next step. Kirsten, I guess, would we envision, just a follow-up place marker for follow-up discussion about review of questions that we might further have with the team, post that conversation with community?
Well, I guess first we need to define how that conversation with community happens, right? We don't have space, and I was going to be clear, we do not have space in our September meeting to do an hour of receiving that testimony. And October is the retreat. So I think we could identify a separate date when the board gathers to receive and invites this testimony. We could invite testimony written that we then all commit to read before discussion.
So I think Claire suggested it could be a synthesis of the feedback that the staff has gathered through this cumulative effect or the cumulative process of the various peer review boards and the transactions and so on that might be helpful to have as well.
There are a couple of things. Sorry, this is Brenna Johnson, just a couple of reflections. One, I'm somewhat concerned about a sense of urgency for it, and I appreciate what you're sharing, Claire, in terms of time sensitivity on the structure. I would rather get the modeling right now than to punt it, for the sake of the function, which that I appreciate the intensity around it, the rulemaking process itself is cumbersome, no doubt. But to me, the consequences of not doing our job effectively by gathering community feedback and the weight of that is so significantly higher than the function, frankly, from my perspective, of the reviews themselves, that to me, going too fast without doing to the point, if it's a synthesis of existing feedback we've received, that's great. Making that publicly available for other people to look at that feedback and suggest improvements. And then we can consider the pros and cons of those improvements and any mitigation strategies about the cons or the challenges to the program itself. To me, we're doing our job when we do it that way. And what I'd like to suggest too, just generally speaking for the board, is that when we know that there's some emerging time sensitive something from an agency that we're going to have a role and responsibility with, how do we get upstream? So it's mostly for the team to consider what are the next waves of things that you're going to need to bring into our board and make sure our board leadership has that calendared so we can feel like we're well supported in doing the community feedback process that we take to feel responsible to do. So that's both. Yeah, go ahead, Claire.
Yeah, I mean, just one thought, and Zachary, sorry, I see your hand raised, so maybe add on to this or feel free to modify it. But the program was also planning to do listening sessions in advance of rulemaking. So that's in addition, if we're adding the layers, I guess that's like a third layer. And so perhaps that would be an area to coordinate and bring some
yeah, do some joint listening sessions that would be informative to that process. So Zachary, please jump in and see if you have any other thoughts on that point.
Yeah, great minds think alike. That's exactly where I was going to go as well. Yeah, September, October, the team was planning on doing public listening sessions for any input at all about the program. You know, that was almost like a pre-step to the rules so that we could solicit ideas, get folks feedback, get folks thoughts, and then incorporate that into the rules development process, then have a rules advisory committee, and then go throughout the kind of the typical rules making process. But we could easily kind of tie in the public input sessions with the Oregon Health Policy Board in some way, so that we're hearing those thoughts, not only about maybe the program operations, but potentially also about these underlying criteria. And perhaps it's kind of a parallel process. Initially, I was thinking we'd land on the criteria and then start on the rules, but I suppose we could have them both kind of co-occurring at the same time. And just if I may, just a quick statement about kind of the importance of having these criteria that the board has previously codified in the framework. The reason it's so critical is because, as Dr. German said, you know, these transactions differ from each other. There are different types of entities. They can be clinics, they can be pharmacy benefit managers, they can be hospitals, they can be durable medical equipment suppliers. It's a lot of different types of entities that are engaging in these transactions. And so having the criteria that really does kind of create the basis for how we approach the review and how we even impose conditions on an approval. There's been about a dozen approvals with conditions that the program has made. And all of those conditions are really predicated on the criteria that the board has discussed and adopted. So I just want to kind of convey the importance of having these criteria really clear and spelled out.
No, I'm just complimenting both that reflection, Zachary. Thank you very much for it. And Claire, your notion of the listening sessions that are already scheduled. It modifies my concern. And I love the idea of having two parallel processes that we just kind of stay close to what we're hearing through the synthesis, through the community sessions, engage those directly, and then offer our early thinking on criteria to help withstand what I think is going to be even more pressures to the program in the environmental context that we're in. You know, so as we imagine what have we learned so far that frankly, Zachary and team, if you had to do it over again, you wish you would have X, Y, and Z, you know, you wish you would have known certain things that from your perspective didn't go as planned. And then certainly for the people that have engaged the HICMA program, getting their pros and cons and concerns, you know, outlined plus ideas for improvement. We're coming into times that are more perilous, and I think that this program is going to be tested significantly. So, yeah, getting it right. Thank you.
So this is Kirsten. What if what I'm hearing is both a request for some sort of synthesis thoughts, compilation from OHA, from the HICMA department. Tony, I just saw your hand. Sorry, I didn't see. HICMA department. For program, sorry, for OHPB to review. You are planning, OHA is already planning public input sessions. Like to, if OHPB could be invited to those to listen in, that would be great. And then we will identify an OHPB meeting that is on the other side of these listening sessions where we will come and finalize the framework and guidance following this input. Does that sound like a good plan, Tony, Melina?
That's wonderful. Yeah, essentially that was why I raised my hand. I think you summarized kind of approach that I think would work very well. You know, and just an added comment that given the context of our health system and the changes that are going to take place post HR 1, I think the concern of further consolidation is more present than it ever has been. And so I really appreciate our attention to this.
Great, so, go ahead, Phil.
Sorry, I have one more thing. I think this is the right direction. This is Bill Krager. This is the right direction to go in. Wanted to ask whether, another change to the process might be possible. I hear very clearly the urgency around, providing the fee schedule for the financial sustainability of the program. That sounds like it's urgent. I wonder if that could be handled separate through a rules process related just to the fee schedule. And we could fast track that and get it done. And there'd be a separate set of all the other rules. Where we could take the appropriate time to consider all the public input, other modifications to the program, rules and regulations. Give us how to make sure we're well grounded in the guidelines that we're providing. I know having a rules process, there's some administrative costs. It seems to me there's talk about one thing that's very urgent, very concrete, another set that's urgent, maybe warrants more time to fully consider some of the modifications. I'm also being influenced here by Brenda's and Tony's comments about, hey, we're entering into a period of financial stress, the entire healthcare system and for all people in Oregon. And there will be probably a push for a rapid consolidation and with potentially major impact. And we should make sure we're doing this right. So, question to Claire, I guess, or Zach, whether it might be possible to consider having two separate tracks on the rules.
Zachary, do you want to take that one first?
Yeah, sure. Yeah, thanks for asking that question, Bill. It's a really good question, and I'd like to take it back and discuss with the team what kinds of options we may have, because it behooves us to really think through all of that. One thing to note is a couple things. One, the rulemaking timeline, it takes about 4 to 5 months from stem to stern, given all the requirements, there's notification requirements, you have to collaborate with Secretary of State, post in the bulletin. There's a lot of kind of steps that need to occur, and there's a specific timeline for each step. So if there are kind of other operational, even non-fee related, but other operational components that folks would like to see sooner rather than later, then that's just one kind of give and take of the process. Secondly, and just to kind of call it out, neither good nor bad, but there is to embark on a rules process, let's say if we're to do it twice in a given year, there is kind of a administrative cost to that because someone has to do it. Now, maybe that's fine, but I just want to call it out as it is. It does require a significant amount of coordination just to conduct all of the steps. But it's something that we'll bring back and fully explore because it's worth exploring.
I think that this is Claire again. I'll just add and maybe just reiterate, I think, both the desire to make sure we're doing it right and we are hearing from community and partnering with OHPB and ensuring we have the right framework. And the bandwidth concerns I think I have. This is a very small team. We did not get funded with our policy option package in the session. So we are, and as the reviews continue, there are follow-up reviews. So the work of the team is growing exponentially while the financials are going the opposite direction. I don't think we mentioned specifically, but part of those follow-up reviews include reviewing conditions. So even if a transaction is approved, they often come with conditions that the team is then evaluating. So Tony, when you were speaking to kind of the success metrics here, that is what we are doing, at least on a transaction by transaction basis, looking at the annual reviews, whether those conditions continue to be followed as they follow with the approval. So I think that is where we are just seeing a little bit of the constraints of a team of less than 10 trying to manage two rulemaking processes and the work of the program. And so we'll again take it back, but I did want to be transparent about some of the constraints that we're operating under.
Great, so we will collaborate with OHA staff and look forward to maybe some refined answers here. We do have, 10 plus minutes still space in our agenda today on this. And I wonder if we want to take that 10 minutes for board members to actually ask questions of Claire and Zachary. Because listening sessions are going to be, it's not about asking OHA questions, right? And so while we have them here, and this is our topic, if there are questions that people want to raise. So like specifically, you mentioned these follow-up reports, and I think it'd be interesting to hear reflections on, that sequencing is set in statute. I think it's been around a few years now. Is there a sequencing that you think would make more sense? Or sorry, Zachary, looking at you too. A sequencing time-wise, or I believe that it's like all transactions that go through HIPAA get follow-up review, no matter what their outcome was. I guess they're denied, but whether they had conditions placed on them or not, they are subject to this follow-up. And so I'm curious if there's a sequencing or like a application subset that would feel more appropriate, both given capacity and what is worth the effort. And I'm also keeping in mind that there is this state of consolidation report that hasn't happened yet, but is coming. That is another opportunity to step back and say, like, okay, we take all the sum of the parts, what is the equal state of work? Would they could provide maybe a relief valve?
Zachary, you want to speak to the reviews, the follow-up reviews?
Sure, yeah, happy to speak to that. Yeah, so Kirsten, you're correct. The statute requires 1, 2, and 5-year follow-up reviews. The program is let's say launched in 22, so we're three and change years old. So we haven't done a 5-year review because we haven't gone there yet. But we've done a number of 1 and 2 year reviews. They are labor intensive because we do want to go back and reflect on any potential concern that we had about the transaction. We go back and look at the public comment that we received during the review process and ask the entities, how have you dealt with such and such an issue? Whatever those concerns may be. They're different for each type of transaction. So that's one of the mechanisms by which we actively incorporate public comment, not just from the initial review, but we actually solicit public comment again during those follow-up reviews to try to get input from the community who are accessing care or living in the community in which those entities operate. In terms of the different, go ahead. Yeah, go ahead, please.
How is participation in the comment period in the 1 year, 2 year?
How is participation done? Is that what you've done?
No, how is it? Do you get comment?
Do we get comment? Not as much, nowhere near as much. We send out our Gov delivery, which goes to about 800 subscribers. We try to get it, via all the different kind of public relations mechanisms that OHA has. So we try to get the word out. Historically, we haven't received much public comment in those follow-ups, despite our efforts to get that engagement. We definitely get more during the our review, or preliminary or comprehensive review. Yeah. In terms of is a different cadence better? I will say that after 1 year, we get information from the entities. We request a lot of different types of information, again, based upon the potential concerns that we flagged during the review or public comments that we received. There's very little, for example, claims data. The claims data is such that there just really isn't a whole lot of reliable claims data with that short of a turnaround. It takes about a year and a half or so for kind of utilization pattern trends to show up in the data. But we get other data. We get more qualitative data. So 1 year is kind of it's kind of a different beast than a 5 year, just because you're gonna have a lot more to look back on.
Thank you. Brenda.
Zachary, can you give us a little picture of some of the conditions that have been applied on the program? So some specific themes of conditions.
Sure, yeah, we've done a number of conditions, really across all those 4 domains that I mentioned before, cost, access, quality, and equity. We've had conditions about certain types of services need to be maintained, be they maternity services, certain programs that work with folks living with diabetes, they have to be maintained. We have even had specific kind of cost conditions. We've had conditions about you have to maintain certain relationships with insurers so that folks can continue to access services. We've had other conditions about trying to think of the many different conditions about notification requirements to patients. If certain changes are going to happen, you have to notify patients. So that's kind of just a flavor. Maintaining service locations. So some of these entities actually have, 3, 4, a dozen satellite locations. And so we've had conditions where they have to maintain and continue to operate those conditions, those locations. We've had conditions about, and this is before the state legislature actually enacted this, but we previously had conditions about non-compete clauses. So we said, okay, this transaction can occur, but you can't prevent a provider or an employee from going to a different clinic in that same town or in the area. So we've done that. Maintaining certain levels of charity care. Those are just a handful of the ones that I can think of, but that's the flavor.
Thank you, Zachary. Just one quick follow-up. What happens if someone does not meet a condition?
Yeah, so if someone doesn't meet it, meet a condition, they we have a full range of legal options. We kind of send them a notification saying you're out of compliance. Then we'd work closely with our Department of Justice colleagues and escalate legal proceedings potentially.
Have you had to do that?
We have issued a letter of non-compliance, and that was sufficient at that time for them to come into compliance. So we haven't had to go the full path of all the different legal recourses we could do.
And then, thank you. This is Brenda again. Just a question about public transparency. How often are we communicating to the community about the conditions of a specific transaction proactively? And either at the time that the decision around the transaction has been made, so community knows what to be on the alert for, yeah,
great question. So as soon as the program decides, is this a approval? Is this an approval with conditions, or are we moving this to comprehensive review? So that's at that 30-day mark. As soon as that happens, we publish the report, which includes the decision and the list of conditions, if applicable. So that's done simultaneously. And then that way the public can see, oh, this was approved with conditions. Here are the dozen conditions or 4 conditions, whatever they are. And it's clear for the for all to see. So we send that to the entities and post it publicly at the same time.
Melina.
Yeah, I was just wondering, how are you setting the bar or measuring the pillars of access, cost, quality, and equity?
Yeah, this is a great question. So it's really transaction specific, but we'll look at things like historical. Sometimes these entities involved in the transaction have engaged in other transactions, maybe in other states, and so we kind of look at the history there. We look at their stated commitments. So a lot of times when they submit a notice, of material change transaction, which is required, they have to submit a notice. They'll detail their plans. And they'll say things like, we intend to keep the same amount of services. We don't anticipate closing this satellite facility, for example, so that for in terms of access. And so there are many times in which we build that in as a condition. Say, well, if you're committing to it, then you're going to commit to it. So it really is specific to the types of entities that are involved in a transaction and the nature of the transaction itself. Sometimes you'll have a full acquisition, other times it's maybe a joint venture where ownership isn't changing necessarily, but there's a new partnership involved. So it really does depend on the nature of the transaction and the entities.
But there is some detailed sub-regulatory guidance that offers very specific examples of how, say, access can be measured.
That is true.
And change in access will be noted. So.
That is true, correct, right. We have detailed sub-regulatory guidance as well as very detailed rules about what that entails. And if I may, just as a side editorial, folks are aware that the program has been sued twice. So we've had 2 bouts of litigation. The state has won both times. And the judges in the ruling, at least in the latest ruling, even kind of referenced the clarity and comprehensiveness of the rules and sub-regulatory guidance documents to show that this program is clear. The rules of the road are pretty clear here. So that's been helpful, and I think we will continue that.
Tony, go ahead.
Yeah, thanks, Zachary. We talked about this the other day, is thinking about upstream mechanisms. And also I think pertinent to this conversation is what does HCMO learn to find where consolidation is good? Because there certainly is some spaces where that is improved delivery of care. And then also learning, and it's great to hear, you guys incorporating the study from across different states and in our own state and reflection on that, the review process of the 1, 2, and 5 years with that. But how, I think it's helpful for us as a board and to think those, and I'm sure this is being shared with OHA leadership, the learnings of where we can be impactful on preventing consolidation where it isn't good. And so I just would like to keep that as an open door in conversation to learn from what HCMO is doing so that we can pay attention to that, some of the other work we do in our other subcommittees or as we continue to focus forward for our state.
Kirsten, I'd love to piggyback a little bit on that, specifically with the state of consolidation report that the HCMO program is part of the HCMO program every 4 years, taking a look at consolidation broadly in the state. And I would love OHPB to create a home or space for hearing that report. And acknowledging the kind of policy implications of the program and consolidation going forward so that we can incorporate that into our own committee's work and I don't know how other people feel about that.
Agreed.
I appreciate it. Tony, you see your hand?
Love that idea.
All right. That's great. Okay, Bill, and then we will wrap it up.
Just quick, I just wanted to say that I think the HCMO program is one of the flagship programs where it's trailblazing when it was created. It showed a lot of strength, and I'm a big supporter. I think but I think it probably could be strengthened, taking some rewards and stuff the last several years, and perhaps streamlined. I think the urgency of getting it financially stronger has to be a top priority, and we should do what's necessary to make that happen, but also look at some other ways of strengthening, streamlining the program through the guidance and the rules process. Really appreciate the tremendous work that Zachary and Sarah and the team do, and leadership of Claire and others. It's a good program. Let's keep it strong and make it stronger possible.
Okay, great. Thank you, Zachary. Did you wanna say something?
Just one closing comment. Again, just thank you all for engaging in this topic with us. It's incredibly helpful. And now, as I think about kind of the lifetime of the program, as I mentioned before, it's been in effect for 3 years, 3.5 years since 22. So it's a perfect time to revisit the criteria that the 21 board members discussed and approved, and that makes a lot of sense. And it wasn't that long ago, even since 2020 or 21, a lot of these transactions would have just occurred, and the public would have known about it after everything was closed, right? After those transactions had occurred. There was no opportunity for community input, no opportunity for review. So we're in a different space now, and it's helpful to think about how the program can improve, and what modifications to the criteria the Oregon Health Policy Board wants to see to kind of underline and create that foundation for the program.
Great. Thank you for really standing up this new program. You've been at it the whole time, Zachary. Appreciation for the HIPMO team. Okay. Great, thank you everyone for sharing your thoughts and feedback. Next up, hopefully Alex is joining us via Zoom. Because our last agenda item is from the Health Policy Board's Health Equity Committee. We refer to as the HEC. The committee is requesting approval for 2 new board members, and the proposed new board members are included in attachment 7 in today's board meeting packet. Alex Freeman, OHA's lead staff for the Health Equity Committee, joins us remotely to preview this proposed slate. Alex, begin whenever you are ready.
Thank you so much, Kristen. And let me just check to see how my sound is. Y'all can hear me okay in the room and online? Getting some thumbs ups. That's great. Well, as Kristen so pleasantly introduced me, my name's Alex Friedman. I use they, them pronouns, and I'm here on behalf of the Oregon Health Authority in my capacity as one of the lead staff for the Health Equity Committee of the Oregon Health Policy Board. It's my great pleasure and honor to serve in that capacity. And I also just want to give a shout out to my colleagues. I know that Maria Elena Castro is here, has been just an incredible mentor to me in this role. And I know that we have a few other folks representing the Health Equity Committee in the audience. We have some other staff as well, including Christine Singh is going to be stepping up more, so you'll see more of her. But it's great to see you all. I know that I fulfill a few different roles in the agency, including working on gender affirming care policy and in the equity inclusion division. But let's talk about the Health Equity Committee today and the recruitment that we did for these 2 new seats. Okay, next slide. Just a quick overview of our current structure. We have 2 co-chairs, and we have some extended leadership roles for our previous co-chairs as well as a kind of a model that we're working on to bring in co-chairs in training. But right now, our co-chairs are Beck Fox and Andy Walsh. I'm sure that you all have seen them and worked with them before. They're fantastic leaders. And then our liaison from the Oregon Health Policy Board to the Health Equity Committee between them is Dr. Rosemary Hemmings. And then the staff, as I mentioned, Maria Elena Castro and myself. And then I didn't put Christine Singh on here. One of our new hires on our team has been incredibly helpful, and you'll see much more of her. Okay, moving on. Quick little overview of our recruitment process for this spring. We had 2 departing members from the Portland metro area, so we were recruiting 2 new positions to fill those gaps. We use an intersectional gaps analysis tool, which is something that we're working on at the Oregon Health Authority to use that in a more widespread way. But that helps us to identify the priority representation areas that we're trying to fill with our recruitment. Our recruitment window was open in May from the beginning to the end. And we do that outreach through a variety of different channels, including through our Health Equity Committee members, through the Oregon Health Policy Board's channels, and then other external relations channels, including formerly known as the Community Partnership Outreach Program, now the Office of Community Health Engagement at the Oregon Health Authority, regional health equity coalitions, and CCO and provider networks. And then for the scoring, we use an intersectional scoring rubric that incorporates the lived experience and identities compared to the priority representation areas from our intersectional gaps analysis. That helps us really understand, and not just who each individual is, but how do they fit into the wider picture of their lived experience with the type of lived experience that we're looking for to deal with the problems that the Health Equity Committee is tasked with. And then for the scoring itself, we have current Health Equity Committee members and equity and inclusion staff, like myself and Maria Elena, that help to score those applications. Okay, just a quick overview of those priority representation areas that we're currently working with on the Health Equity Committee. We are looking for people who have lived or cross-cultural experience as part of communities of color, immigrant and refugee communities, the people with disabilities community, LGBTQIA2S+ community, experience as an Oregon Health Plan member or direct experience with Oregon Health Plan members, people who are younger than 35 or older than 60, people who are in rural Oregon. One more that I want to mention on here that's not listed, just people, I think I would say it as a variety of different professional and systems perspectives. So not just people who are in kind of director level positions, but also folks who are staff or recipients, patients, variety of professional perspectives. Okay, moving on. So here are the two individuals that we're proposing to add to our current slate. I do just want to mention that we're going to give limited kind of demographic realty SOGI information, especially with such a small number of new additions. Sometimes we share some graphs and data, but to protect identifying information, we're not going to do that today. Also just want to say in our current climate, we've experienced increased scrutiny around the identities that are represented in our committee work. We're doing extra labor on the OHA side to protect that identifying the potentially dangerous information in the wrong hands in our public work. Okay, so that being said, we have Kara Rodella and Michael Thurman as the two proposed candidates. I think Kara is here, by the way. Just want to say hi, Kara, and I hope that I said your name correctly. And I want to say a little bit about them. They've had such amazing things to say to us in their applications. I think in the next two slides, we have short bios. Yeah, so I'm just going to read these out loud so you all know who it is that you're approving. Kara is passionate about Black maternal child health, driven by her experience as a young single mother. She earned a degree in community health and a master's in public health to create culturally specific programs for her community. Kara has over 20 years of experience in Multnomah County, successfully building and implementing community-driven programs that are culturally and linguistically specific, addressing the issues that matter most to the community. Currently, Kara is the Health, Equity, and Community Partnership Director for the Coalition of Community Health Clinics, where she is dedicated to improving health access for the underinsured and uninsured. Excellent. And one more slide. Michael Thurman. Michael has personally experienced discrimination and stigma due to Michael's identities, medical conditions, social security disability status, and being unhoused. As a result, Michael's become an advocate working to reduce access barriers for marginalized and culturally diverse communities in receiving social services. For over 8 years, Michael's volunteered with the Cascade AIDS Project, and Michael's founded, joined, and chaired numerous advisory groups in Multnomah County, including the Equity Committee, the HIV Planning Council, the Adult Mental Health and Substance Abuse Advisory Council, Care Assist Advisory Group, and the Oregon Statewide HIV and STI Viral Hepatitis Group. I think that's everything I have to share with you all. Happy to answer any questions, and then I hope that you all can move to vote on our new slate. Thank you.
Great, thank you, Alex. Are there any questions from board members or Alex regarding the proposed slate?
No questions, Alex. This is Brenda Johnson. I'd just like to move approval to the Health Equity Committee slate as proposed.
Second.
Thank you, Brenda. Thank you, Peter. Okay, we're gonna do roll call vote. to approve the recommended health equity mini slate.
Okay, I'll start online with Melina Moran.
Aye.
Tony German.
Aye.
All right, Brenda Johnson.
Aye.
Peter Starkey.
Aye.
Bill Kramer.
Aye.
Chris Isaacson.
Aye.
All right, all vote yes. Stay approved.
Welcome to the Health
Thank you
Equity
all so
Committee.
much. Really excited to have these new members join us.
I'll say I heard that there are a lot of applicants too. It's like a robust pool, and that's really impressive given the 30-day application window. And I think it speaks a lot to the work that the Health Equity Committee has done over a lot of time here, building relationships and outreach. And so, well done, and trust. There you go. Yes. Okay, well, this brings us to the end of our meeting. I do again want to give a special thanks to the community panelists that we had today, to the Birch Grove Collaborative for really bringing all of their voices into the space today, to On Track Row Valley for hosting us. It's been an enlightening and invigorating time here in Southern Oregon and Medford. So thank you to all our hosts, and I'm so appreciative that we made it to Brenda's backyard. Finally, thank you so much. Yeah. So our next meeting will be September 9th. That will be a remote meeting. We'll join via Zoom. Our all-day retreat will be in Portland, October 7th. See everyone there. Not November. We're going to stay with October because that's when more board members should make it in person. And okay. So that'll be great. Look forward to it. I think between now and then, I'd say stand by, right? We'll be hearing dates that we want to be tuning in to these OHA listening sessions around HICMO. We will be tapping on shoulders to participate in retreat prep in different ways so that we come to that space ready to have great activities and collaborate and focus on our priorities or set our priorities for the year ahead. So I'll say that. So much work to be done. Thank you, everyone, and thank you to OHA staff. Sorry, in all our work with our hosts with On Track, they do part of the work, but there's a team OHA staff that also came in last night, came in early this morning to make sure everything ran smoothly, which it absolutely did. So thank you.
We didn't have to blame the robots.
And with that, we are adjourned. Thank you.
Thanks, everybody.